Okay, guys, so this session is all about confidence, then control, and closing the gaps and closing the year as well. This happens to be my last session of this particular year. So we end 2025 with a lot of clarity with respect to what you and me will be doing in 2026. And that's going to be the test and the explanation part. That is a new series that is being conducted at the moment. And I'll be discussing all the subjects over the span of next approximately 3.5 months. So for those of you who are new to this, what I want to say is that for the schedule, you can either message the number that is visible on the screen, and even for the unannotated PDF, what we follow is that the unannotated PDF comes to you or is available to you just at when the session would start, so that you can take the notes in that only. And then subsequently, like, my main focus would be to help you get to the right answer. So okay, guys, time to rock and roll, because pathology is one subject where I think like the patient is already dead most of the cases. And though the patient is dead, this subject is going to be like phenomenally affecting the rank. It's going to shake up your rank. So examiners are more interested in trying to know or they are more interested in trying to know who would panic first. The common things are asked, like it has been in this particular paper, but then you would have felt that some questions look very straightforward. And when I discuss, then you'll realize that whether that answer was correct or not. So let's hit the comment button, guys, and get started for today. Again, like if you want the unannotated PDF, then this is the number, and I would not be able to answer for the PDF in the middle of the chat because I'll be focusing on the academic part. So here we go, guys. The first session of the TNE for NEET PG, and at the same time, like the last session of this particular year as well. So it's all about, like I said, confidence, control, and closing the gaps. That's what we want to do. And yep, do let me know with respect to the audio and the visual part if everything is fine, so that we can get going for today. Okay. So I think the duration of the T&D will vary according to the subject, but something should be in the range of about 3 to 4 hours. That's the primary objective, so that we are able to do justice to the subject. So let's get started. Hit the comment button, guys. The first one is about an excised heart tissue from a 25-year-old woman with prolonged fever and shortness of breath. And then there's an exercise intolerance and a diastolic murmur as well. So I think the question becomes a little obvious with respect to the manifestations that are given. And yes, guys, I mean, it's your day and your time that you are the ones who would be prompting first, and then I'll go ahead with the subsequent ones. Hi, Subhendu, Vinay, Abhishek, Osama, Akshay. So I missed a couple of names in the app for the chat. So great. I think we are finally in a position to discuss. In this particular case, I'll just zoom into the slide as well, so that you are able to make a better decision with respect to the image that is given here, because ultimately pathology, like I said, the patient is dead in a large number of cases, and then we have to subsequently analyze what went wrong in this particular chap. Yes, guys, so thumbs up. Nahi. Now we would like answers in this case. There is like prolonged fever, shortness of breath, exercise intolerance. So considering that there must be something related to the heart valve which could be contributing to this. The first possibility that I'm considering in this question is a cardiac sarcoidosis, where there would be a non-castrating granulomas. But then most of the time, the cardiac sarcoidosis would contribute to development of a cardiomyopathy. And if I'm talking about a cardiomyopathy, like dilated cardiomyopathy, etc., most of the time it will result in conditions like mitral regurgitation, which will cause a pansystolic murmur. In contrast, if I focus on the slide in this case, like Ishant was the first one to mention here, D versus, like, I'm having all kind of answers coming up, 25% for all of them. So you can see the stellate cells. You can see the spindle-like cells which are present here, and then you can also see some nest of cells present here. So first and foremost, what you need to pick up here is that there are some spindle cells that are present. Then more importantly, apart from the spindle cells, there are a couple of nests of cells that are present. And these nests of cells tell me that this is not going to be rheumatic etiology, because rheumatic fever is something where I'll be, coming up with the rather manifestations of Ashkoff nodules, and there's a separate slide that I'll be discussing. No, guys, this is not a case of rheumatic fever. I understand the fact that whenever you are gonna go through this data, the first thought process in an Indian exam would be if he's gonna talk about like shortness of breath, exercise intolerance and diastolic murmur, अब rheumatic fever के बारे में सोचते हैं. But मैंने तो hint दे दिया भाई. I have said that there are spindle cells, there are nesto cells which are present in this case, which will help in diagnosis. क्योंकि cardiac sarcoidosis में तो cardiomyopathy होगी, that will cause mitral regurgitation. So now I've ruled out two options for you. And infective endocarditis, well, why would I do an excision? Like I would not excise a particular tissue. The correct answer for this one is option number C, guys, cardiac myxoma. The myxoma will be contributing to development of a diastolic murmur because it will obstruct the inlet of the valve. But for today, you don't need to study medicine. You don't need to get into like, what is the valvular lesion that is responsible. All you have to pick up is from the slide that is given. There's a lot of abundant connective tissue present here. And apart from the abundant connective tissue which are present, like I said, the main feature which is present in this case would be those scattered spindle cells. And I can call them stellate cells, I can call them spindle cells, would help in identification. And this is mucopolysaccharides which are present. So this would be PAS positive as well as LCN blue positive. And another differential that I would like you guys to be very clear about is they can give you an image with respect to those large vacuolated myocardial cells. Now, if it's gonna be those vacuolated myocardial cells, then I can say that those would be like a spider cells that would be present in this case. But then if you look at the options for this one, all other options don't make sense. Infective endocarditis will not go for an excised tissue, इसलिए बाहर हो जाता है. Rheumatic fever में तो जो Ashkoff nodules वाली slide होती है, caterpillar cells होते हैं, the appearance is totally different. So what we are thinking in this particular case would be a cardiac myxoma. That would be like the most appropriate option from the ones that are given in this case. And like I said, the main feature which is present here would be those abundant myxoid polysaccharide cells, and then there would be spindle chipped cells, and the cells arranged in nests as well. So I think we sorted for the first question for today. It is just that the exclusions had to be practiced for this one, and we can move on to the second one. In case you had any issues in understanding this one, then do let me know. Otherwise, I think it is pretty straightforward one. And I am not relying on the murmur for solving this question. I am relying on the findings which are present in this particular case, which would help me identify the presentation much more relatively better. So I think we are good to go for the second question for today. Where I'll zoom into the slide so that you can focus on it relatively better. Like he says, which of the following presentation is most likely based on the histopathology report, and like everything is related to the thyroid gland only. Now, if I zoom in, तो आप यहाँ पे बड़े-बड़े thyroid follicles देख पा रहे हो, and the key thing that is present here is the scalloping that is present here. So since I've said thyroid, since I've shown those thyroid follicles, you can see the pink eosinophilic colloid in the middle, and then there's a bit of scalloping also present. So what you need to do is hit the comment button for the same so that we can go ahead in evaluating. Because if this was Hashimoto's thyroiditis, then you will notice that there would be a lot of lymphocytic infiltration. There would be a lot of blue cells that would be present, considering the scalloping which is present in this case. And like very, I would say, limited lymphocytic infiltration present. This goes in favor of Graves' disease. And the key thing that you have to identify in this slide, because I think for most of the slides, what is really relevant for you guys is just to pick up the initial few abnormalities in a matter of few seconds so that you are able to get to the correct answer. And since the scalloping of the colloid is present in the thyroid follicles, that is one of the key features for diagnosis of Graves' disease, and Graves would always be having T3 and T4 to be elevated, and the TSH of the patient would be relatively lesser. So I think the correct answer for the first question, that is on the second question on the slide, would be an option number D, that is TSH would be low, FT3 and FT4 would be elevated. If this was a slide for Hashimoto's thyroiditis, तो कैसे दिखेगा? Then for Hashimoto's thyroiditis, you will be able to see a dense lymphocytic infiltrate with well-formed germinal centers. Especially if you look at it, तो यहाँ पे कई वाले जो germinals, कई वाले जो thyroid follicles are, they're bigger. Some of them are relatively smaller. And then if you look at the 10 o'clock area or the 11 o'clock area, there is a lot of dense lymphocytic infiltrate that is present, along with that Hurley cells. Now, Hurley cells may not be visible at a low magnification like for the current slide that I've shown, but Hurley cells, if they give you an enlarged view, would be having a lot of pink eosinophilic cytoplasm, and they're rich in mitochondria. And you are anyway aware that Hurthle cells do not decide whether it's going to be Hashimoto or it could be even related to a tumor like a Hurthle cell tumor. It is the capsular invasion that would be present. Yeah, I mean, Nachiket, you have a good point there that can scalloping be present with respect to Hashimoto's thyroiditis? Then I can say that you need to see a lot of lymphocytic infiltration, like germinal centers, like the ones that I've highlighted for Hashimoto's thyroiditis, in contrast to the slide that I had shown, where it was like, I can say, asymmetrical enlarged thyroid follicles. All of them were not like some are big, some are small. They are all were enlarged, and then the scalloping was like very predominant one. So we have to take into consideration the physical appearance of the slide to identify what could be the disease process. I do take your point that scalloping could have been present, but then if you compare the two slides, the one that I've shown goes more in favor of diagnosis of Graves' disease in this particular case. So the answer in question number 2 would be still given as option number D only. Just like in the first one, no, the assumption was that it could be cardiac sarcoidosis. Sarcoidosis में तो cardiomyopathy होती है, so the valvular lesion will change because MR has a pansystolic murmur. तो मैं तो murmur का तो बोल ही नहीं रहा था, मैंने बोला कि slide से identify हमारे को करना होता है. And then for the second one, like I have shown two comparisons between Hashimoto and Graves' disease, which is one of the common ones. क्योंकि हम traditionally पढ़ के जाते हैं papillary cancer of thyroid and the orphan NAI appearance that is present, but then orphan NAI appearance वाला जो slide है ना वो इतना common हो गया कि अभी तो वो पूछेगा भी नहीं. I don't think so that he's gonna ask you about papillary cancer of thyroid anymore, considering that you guys are so good at it. So that is why, like in the slide, it was more common diseases, and I think that the examiner is trying to check common diseases only. If you look at the pattern of NEET PG, the last time or the last to last time, it's like the routine information that is being asked. So we are sorted for the second question on the basis of the slide interpretation, and we can move on to the next one. Where we are talking about brain biopsy finding of a patient. The chap had presented with the psychomotor agitation, and then like if I say anything else, the diagnosis will become obvious. So I'll just zoom into the slide here, and you guys can do the commenting with respect to the key findings being that aggression that the patient was trying to show, that is the psychomotor agitation that was present. So yes guys, zooming out and focusing on the options in this particular case. Fine, I got a very good answer there, that is Pick's disease. Pick's disease would also be called as frontotemporal dementia. Now, when it comes to frontotemporal dementia in a patient, you usually don't get a psychomotor agitation. Rather, there would be two features that would be very characteristic. One is apathy and second is disinhibition. But to have a patient presenting with aggression for Pick's disease is very unlikely. I'll show you the image for Pick's disease as well. Yes, I think the main thing is, आप देखो ना, मैं slide में zoom in किया तो there is like so many vacuolations that are present. वो जैसे Swiss cheese appearance is an unofficial way मैं बोल सकता हूँ. Those vacuolations are making it super easy for you to identify that in this particular case, like there is a spongiform appearance. I mean, the key word from the pathology domain that I would like to say for this particular slide is the spongiform appearance, and along with the spongiform appearance or a Swiss cheese appearance, that helps us identification of this as no guys, what you need to focus on is not the the neuron looks pretty decent if I zoom in, right? There is no inclusions that can be seen in this particular case or neurofibrillary tangles. What is present is that Swiss cheese or the spongiform appearance of the brain along with the psychomotor agitation, which is a classical presentation of variant Creutzfeldt-Jakob disease. Well, when it comes to rabies, I'll show you the slide. There has to be eosinophilic inclusions inside the neurons, which I'll just come up in like 15 seconds from now. Cryptococcus neoformis में तो cysts होंगी, तो I think all of you were able to rule out the rabies part, and then you were able to rule out the Cryptococcus neoformans part. But what you have to pick up was that FTD presents with apathy, disinhibition, and VCGD mainly presents with psychomotor agitation. But आपको clinical नहीं भी पता, तो आज का जो question है, I mean today's discussion is not about the clinical details. I mean, apart from psychomotor agitation, we also have is development of myoclonic jerks. This would be especially startle myoclonus that would be occurring in this patient. Plus, you might have is a development of a rapidly progressive dementia. So when it comes to prion disease, clinically it presents as 3 points, and then is the classical finding which I highlighted. That's gonna be the spongiform appearance that you can see in this particular slide, which helps us in diagnosis for this condition as prion disease. So the answer for this would be option number B. And like one of the manifestations that we read is called as classical Creutzfeldt. Another one is like variant Creutzfeldt-Jakob disease, and there could be various routes of transmission of these diseases as well. But if you focus on the aspect, like somebody had mentioned regarding Pick's disease, तो Pick's disease में तो ballooned up bodies होंगे ना. When Pick's disease का जो slide होगा उसमें क्या वो देगा, तो they would always be like inside the neurons these ballooned up bodies, and then the silver stain would also be given. So for me to say Pick's disease or frontotemporal dementia, or to say Pick's bodies, there are two things that I need to look for. One is the ballooned appearance, as you can see here. And second, apart from the ballooned appearance, there would be like a silver stain image that would be given simultaneously for me to be able to identify this. If I move to the extreme left hand side, then we have this eosinophilic inclusions that are present in the neurons. That would be for Negri bodies for rabies. And then yeah, Akash, I'll modify, like I'll not call it poor beef, I'll call it like poor quality beef, which is responsible for transmission of prion particles, but it can have a genetic basis as well. Prion is one thing that is transmissible by I mean, not only like the beef part that we're discussing, it can have a genetic basis. So that's for Negri bodies, the ballooned appearance of Pick's bodies. And then extreme right hand side, you can see those cysts in the brain for Cryptococcus neoformans. So these are like 3 slides for the remaining options that I have currently shown before you. And now if I zoom into this image, you can see that very classical Swiss cheese / spongiform appearance of the slide, which helps in diagnosis of question number 3 as presence of prion disease. So you just need to get used to those histopathology slides for interpretation as well. We will be using clinical information to our advantage, but then since it's a pure pathology based discussion, so I'll keep myself restricted to the domain of evaluating the slides only. We sorted for the third one, guys. If anybody has some doubt with respect to the interpretation, let me know. Otherwise, we can move on to the fourth one. Okay, fine. Moving to the fourth one. Which is correct about the slide presentation, and the patient is having an endobronchial lung mass, and the moment I pick up that endobronchial lung mass, I would be able to identify that salt and pepper chromatin in this particular case. I mean, the main thing that is present is the salt and pepper chromatin. So I'm getting fighting between A and B going on as usual. The main thing is salt and pepper chromatin is a feature that we read with respect to both lung cancer and then even with respect to carcinoid tumor. Now, most guys are realizing this fact. If I zoom into the slide, if I zoom in even further, where I'll put this arrow, you will notice that there is a good amount of cytoplasm that is present inside the cells. Like, okay, this is bigger now. So where I'm putting arrow, you can still see the cytoplasm. You are not able to see any cytoplasm inside the cells with respect to a small cell cancer. So it's a good pickup by a lot of people that you were at least able to rule out the small cell cancer here. No guys, small cell cancer वाला जो slide अभी मैं दिखाऊंगा, that will be having intensely blue cells. I mean, those would be increased nuclear cytoplasmic ratio. The mitotic index is much more higher, and all cells will be having a very dense blue color nucleus that will be occupying majority of the cell. But if you get a slide in which you get a combo, and that combo would be having is also a presentation of these cells where cytoplasm is visible, then it would be going in favor of a carcinoid tumor where we get this presentation of, okay, azopardy is a feature with lung cancer, वो तो ठीक है, but अभी तो हम salt and pepper के साथ में 2 चीजें पढ़ रहे हैं ना guys. With salt and pepper, I said one possibility can be that this can be a question on carcinoid tumor. तो भाई कमेंट करो ना चैट बॉक्स में. अभी तो कुछ ही लोगों ने बोला है. I think I mean, you guys have to comment on like whatever you think is the most appropriate one, so that they can guide you into the right one, and doesn't matter whether it is right or a wrong one. तो पहली बात तो ये स्लाइड किसके फेवर में जाती है, तो कार्सिनोइड ट्यूमर की स्लाइड में जाती है. Now I got 2 options that are present. One is Harshita had mentioned, Akash and couple of others. So flushing episodes and diarrhea are seen with carcinoid syndrome, especially if it is GI mets. Yeah, they cause GI flushing, लेकिन वो कब होती है? When there is GI mets to the liver. अगर पेशेंट को अपेंडिक्स में या आइलियम में कार्सिनोइड ट्यूमर है, and that will metastasize to the liver, then the 5-HT derivatives will bypass the first pass metabolism, and that is when this manifestation is seen. I repeat that again. GI mets, they go to the liver. Then the 5-HT derivatives are gonna bypass the first pass metabolism, and therefore that is when you get flushing episodes and diarrhea with the GI carcinoid that has metastasized to the liver. Our case is having a endobronchial lung mass, and carcinoid tumor is very, very vascular, and because it is very, very vascular, it will result with presentation of recurrent hemoptysis with cough and wheezing. So the correct answer for question number 4 is option number A. The message is bronchial carcinoid is one of the leading causes for development of a recurrent hemoptysis in a patient because it's a very vascular tumor. Because it grows in the lumen of the bronchus, so it will cause a physical obstruction that can explain the wheeze and the rhonchi that could be developing in this particular case. So the main point is there were two steps in analyzing this question. Step 1 was to identify that does this slide go in favor of does the slide go in favor of carcinoid or root cell? That is first. So it goes in favor of carcinoid because there are a lot of cells where if I zoom in further, you can see that the cytoplasm part can be picked up. The mitotic index is little on the lower side as compared to that what you get with root cell cancer. And second is to realize that bronchial carcinoid ka presentation kya hota hai. So it is going to be recurrent hemoptysis with cough and wheezing and not flushing episodes with diarrhea, because wo jo bhi banayega, that's gonna be sent into the blood, and from the blood it will pass through the liver, and the liver will destroy or metabolize 5-HT derivatives. So there will be no flushing, there would be no diarrhea occurring in a patient. It is only if it's a GI carcinoid that metastasizes to the liver that it is able to bypass the first pass metabolism. I'll write this data here also so that you can remember it. The 5-HT derivatives bypass the first pass metabolism, and that is the reason why you would get this kind of a manifestation. That is why, like, you know, whenever I have discussed carcinoid syndrome, I said two things: a carcinoid tumor, and second is the syndrome part. And that syndrome is where, like, we read about valvular lesions like tricuspid insufficiency and pulmonic stenosis, for which the mnemonic is TIPS, with tricuspid insufficiency being a relatively much more common valvular lesion. And this was to our two-step question. I'll say this would be a little more difficult than what was put up before you as compared to the earlier ones. Diarrhea flushing will be there to vascular. Yeah, Nachiket, I mean, that flushing part, like I said, is due to 5-HT derivative histamine that will explain that manifestation. So I think we sorted for question number 4, and we can move on to the 5th one for today, where a patient is presented with the adult patient with headache and visual disturbances. The MRI shows a well-defined Sellar lesion, as you can see. And then he has given a slide here as well. In the slide, if I zoom in, you can notice these columnar cells. You can also notice some goblet cells here, which are like empty white areas. And then there is like a lesion in the brain in the area where the pituitary is supposed to be. It's a suprasellar lesion that is highlighted. So you need to identify whether this is going to be a carcinoma. Yeah, serotonin can contribute to diarrhea and flushing. No, flushing would be mainly explained by the 5-HT derivatives, and serotonin can explain the diarrhea component, and that would mainly be a secretory diarrhea component present there. Okay. Moving to the next one. Yes, guys, this is not, I mean, adamantinomous craniopharyngioma to बच्चों में होता. This would be found in a child, so therefore I'm ruling it out. Either it's gonna be a pituitary adenoma, but then with pituitary adenoma be having this, I mean, pituitary is gonna be a gland, no? It's gonna be gland. Here I said two things. Okay, so Bhavna mentioned regarding the fourth one. Bhavna, fourth question, answer cannot be D because उसमें लिखा है hyperkalemic alkalosis. उसमें तो hypokalemic alkalosis होता है. That is one. सो लंग कैंसर के लिए पहली बात तो अगर आप सोच भी रहे थे ना तो डी में हाइपरकलेमिक एल्कोलोसिस से बाहर हो जाता है. एंड सेकंड, द स्लाइड डिड नॉट हैव अ लंग कैंसर, इट वाज अ कार्सिनॉइड ट्यूमर विद द प्रेजेंटेशन दैट आई हैव हाइलाइटेड. नो गाइज, आंसर इज नॉट ऑप्शन नंबर डी टू क्वेश्चन नंबर 4 because one, you don't get a hyperkalemic alkalosis, you have a hypokalemic alkalosis. Our brain becomes numb. I wanted somebody to point out to this fact कि सर लंग कैंसर भी तो हो सकता है. तो भाई लंग कैंसर के लिए फिर ऑप्शन भी मैच करना चाहिए और स्लाइड भी मैच करनी चाहिए, दोनों होने चाहिए ना. None of them are matching. Neither the manifestation is matching, neither the slide is matching. That is why I have ruled out option number D for this. And good that you pointed out platypnea and weight loss is a feature that is going to be seen with the patients. I mean, that's going to be a feature that could be seen with tumors in the heart as well, or hepatopulmonary syndrome. So this was like out, and I mean, most of you would have been thinking about A versus D, B versus D only. So I hope that is resolved as of now. yeah, Bhavna, that is what I've written on the slide. Salt and pepper can be seen in oat cell cancer also. But मैंने difference बताया है. आप दोबारा से वीडियो में पीछे जाओ and listen to the difference between why this slide is not gonna be oat cell cancer. I've explained the difference here. I mean, obviously, patho mein to we'll do a key 67 evaluation, and like this key 67 would be helping in identifying regarding oat cell cancer. But slide देख कैसे पता लगाना है कि carcinoid है या oat cell cancer है, because this is a PYQ, guys. That is what they given. Salt and pepper chromatin is present in both of them. So I've tried to explain कि दोनों के बीच में कैसे identify करना है. So just go back in the video and I think you'll be able to identify that what I've described as a low grade, less mitotic activity wala details as compared to the aggressive one that we tend to see with those people who would be having is the lung cancer. Okay, ji. Moving to the fifth one, like what I was saying was there is this columnar epithelium present, that is one. And along with this columnar epithelium, I have also explained that there would be goblet cells that are present. The combination of these two would help you identify that what we are discussing is a non-enhancing mass on an MRI. So अगर आप तीनों को जोड़ते columnar epithelium, goblet cells and a non-enhancing mass, this becomes a Rathke's cleft cell. So answer to this question is option number C. A was ruled out because that would be related to child. Pituitary adenoma, well, the physical appearance on an MRI would not be like this. And second, pituitary adenoma is a gland, no? So there would be like a glandular appearance that would be seen. So I'm ruling out between two options. What you have to select was papillary craniopharyngioma versus a pituitary adenoma. That's the differential that you have to take into consideration. Papillary craniopharyngioma will show a contrast enhancement. It's more of us like a solid tumor that is present here. There's a cystic tumor that you can be seeing here. Unlike when it comes to I mean, Rathke's cleft cyst में तो नाम ही cyst है ना. Unlike a papillary craniopharyngioma which will be more a solid tumor and will be having contrast enhancement. और जो epithelium होता है इसमें, आप पढ़ना इसको पैथो से अगर आपको नहीं ध्यान है, that यहाँ पे जो epithelium present होता है, that would be a stratified squamous epithelium. So the reason why I am like not answering as papillary craniopharyngioma as one, there's a stratified squamous epithelium that is present. Second, there would be like a solid tumor that can be present. And thirdly, what you can be having in a patient is, yeah, Rathke's cleft cyst usually presents in adults now. It's a differential diagnosis of a papillary craniopharyngioma in a patient. And the histopathological slide is the one that is giving us a diagnosis. That is contrast enhancement would be present. So none of these manifestations are getting satisfied, which is why I'll go for not a papillary craniopharyngioma, but a Rathke's cleft cyst in a patient. So answer is C, sir. I have given justification. सबसे पहले तो देखो histopathology will decide ना. It is not the age group that will decide. I mean, it's the classical presentation is that of columnar epithelium, which you can be seeing here, along with that goblet cells. That is one of the features that is highlight of whenever you read pathology. First thing madam would have said is Rathke's cleft cells के जो cells होते हैं, they would be having the current manifestations. The question would have been easy. I agree. If I asked you about adamantinomas craniopharyngoma, where the standard keratin pearls wala slide I would have given you, then I'm very sure like everybody would have grabbed the question right on by like, you know, I mean, then it would have been super easy for you to identify the question. So what I have not done is given you the classical slide that is of a craniopharyngoma where those where the wet keratin would be present. As you can see, what I have given you is a slide where you are supposed to rule out the options. That's what not NEET PG is all about. That the questions to sune lagte hain. The questions look like, you know, ki, yeah, I have read the data, but then that wet keratin, what you read for this particular topic for craniopharyngioma, मेरे ख्याल से तो slide देखने का भी जरूरत नहीं है. No, he'll begin with like a child who's not able to copy from the board, supracellular tumor, maybe manifestations of diabetes insipidus would be given, so it becomes relatively easier for this particular case. So what you need to pick up, Aditya? Okay, so आप age group से solve कर रहे हो, मैं histopathology से solve कर रहा हूँ, बस इतना ही difference आ रहा है. Okay. So if you look at the manifestations for adamantinomas one, it would be found in children with a calcification. Then there would be the most important thing is the calcification that is very visible, whereas papillary may solid hoga with the contrast enhancement as I explained, and then the epithelium part is also going to help in differentiation. So अभी अगर आप इस क्वेश्चन को दोबारा से देखोगे ना, तो you will soon realize that this was obviously not craniopharyngioma and a pituitary adenoma, and if you were thinking about B versus C, you had to look at the slide for coming to the final conclusion with respect to the answer. So the fifth one is option number C, pure histopathological information, and we move on to the sixth one for today. 60-year-old patient with shortness of breath and ankle edema. एक क्वेश्चन ऐसा आना ही आना है where there would be cardiovascular complaints, and then the patient died also. So he has given me a postmortem heart examination findings as well. He has given me a histopathological slide as well. So I think you guys can quickly comment with respect to the answer for this one, and I would be in a very good way or position to then tell you regarding what is to be done. Okay, arrhythmogenic right ventricular dysplasia would be having fat present in the myocytes. So there would be fat in the myocytes because there is like I'll show you the slide also. Arrhythmogenic right ventricular dysplasia is a presentation in young people. If you read the question carefully, it is written septal thinning, and it is also written dyskinetic left ventricle. So it is not a hypertrophic cardiomyopathy, because in hypertrophic cardiomyopathy, the septum will be becoming mota, and there would be like even the free wall of the heart becoming relatively bigger. So the answer in this question is not hypertrophic cardiomyopathy again. Why? Because उसमें तो septum मोटा हो जाता है. In this particular question, no guys, the answer is not B for this one. इसमें तो septum hypertrophy will occur. I mean, you know, when we read about HOCM, the first thing that we have is not septal thinning, septum becoming mota. So it's not A, it is not B. Now between C versus D that you have to work. Restrictive cardiomyopathy, there would be fibrosis present in the myocytes of this particular patient. So I mean, your finding of restrictive cardiomyopathy क्यों गलत आ रही है? Because उसमें wall की thinning नहीं होती है, wall becomes stiff. Here he would have said the word stiff chambers of the heart. It is stiff wall because there is a presence of fibrosis in the wall, whereas what the question is saying is that there is a thinning present. Now thinning can occur either due to dilated cardiomyopathy or it can occur due to a ischemic cardiomyopathy in this patient. So the correct answer in this question is option number C. And यहाँ पे कुछ myocytes जो हैं वो तो damage हो गए हैं, कुछ का compensatory, they can be like an increase in the thickness as well. So what the question is trying to say is rule out my options. I'll rule out the options once again. Option number A is ruled out because there should be fat in the myocytes. I'll show you the slide for the same. This would be a slide where like fat to wash off ho jata na. So this would be a slide that would be rather favoring arrhythmogenic right ventricular dysplasia where right ventricle is involved. Then is the helter-skelter appearance of the myocytes. That is a feature that you see with hypertrophic cardiomyopathy, but then there should be hypertrophy of the myocytes present. Then is a slide where you might be having rather hypertrophy of the myocytes. Yes guys, if he says the word there is a hypertrophy occurring in the myocytes, then I mean, that's a feature that you see with dilated cardiomyopathy. That's again a peculiarity because some myocytes will die and the remaining ones will try to take over the function. And lastly, he can give you this classical specimen where the size of the atria is jumbo. I mean, you can look at this image. The atria is bigger than the ventricles of the patient. The atria are bigger because there is a fibrosis in the wall and therefore the atria are having to work against a resistance. And you can also notice in this slide, this pink material, atrophied myocytes are present. And along that, you can notice the pink hyaline material which is deposited, which will subsequently also be showing a classical starry sky appearance on an echo, right? This cardiomyopathy that I'm describing at the moment is restrictive cardiomyopathy, RCM. Restrictive cardiomyopathy mein, when we do a echocardiography, that shows that very classical starry sky heart. I mean, normally we start about starry sky kidney for PSG and we read about starry sky appearance on a non-contrast CT head for neurocysticercosis, but then we also read about starry sky appearance with respect to amyloidosis, which is one of the leading causes for the rarest kind of cardiomyopathy. Now, okay, Nachiket says why septal thinning? Because the septal artery, the septal branch of the LED can also be obstructed. So therefore the blood supply, the septum can also be affected. So that's where the interventricular septal thinning can be seen in this person. So we'll answer this as option number C only, that is ischemic cardiomyopathy for this. So be assured, guys, one question on cardiomyopathy will always be there, and one question with respect to neurodegenerative disorders will also be there. Now, whether it's gonna be prion disease, whether it is Alzheimer, or whether it's gonna be frontotemporal dementia, like I showed you the PICS bodies and the classical appearance of them, that's I mean, anybody's guess which of them can come, but you need to be very ready and thorough with the slide interpretation for each one of these relatively common conditions. So great, guys. We are doing a great going for the current session. Let's move on to the next one. We have this patient with a muscle weakness involving the lower limbs with dry mouth and a cough for past 3 months. And then there is like starry sky for no, bache. Starry sky is the finding for restrictive cardiomyopathy. And that starry sky is the finding on echocardiography for amyloidosis. Na? Basically, amyloidosis का speckled appearance आता है. The amyloid is deposited in the myocytes, between the myocytes. So that causes a speckled appearance. That's a echocardiography finding. And from histopathological perspective for RCM, I'll say again, the atria size is bigger. Ninja star वाली slide जरूरी थोड़ी ना देगा. भाई निंजा स्टार तो तुम पकड़ लोगे बिकॉज दैट इज द फर्स्ट थिंग दैट यू विल स्टडी इफ यू चेक आउट द क्वेश्चंस ऑफ द प्रीवियस ईयर्स ऑन द टॉपिक ऑफ कार्डियोमायोपैथी. उसने एक बार भी अभी तक आई विश निंजा स्टार पूछे यार. आई विल बी सो हैप्पी यू नो कि आपको स्ट्रेस ना हो और आपको बोलो यार तो बहुत सुपर इजी क्वेश्चन पेपर था. बट देन लाइक यूजुअली इट हैज नॉट बीन द केस. सो आई थॉट आई जस्ट डिस्कस दिस कॉमन स्लाइड्स विद यू सो दैट यू आर इन दैट टॉप स्पॉट पोजिशन टू बी एबल टू आई मीन भाई धुरंधर स्टाइल खेलना है ना कि चुप चुप रहना है एंड देखते रहना सब कुछ. लेट द एग्जामिनर डू ऑल द ब्ला 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 एंड देन चुपके से बिल्कुल आंसर सही मार देना है ना. दैट्स हाउ यू आर सपोज टू प्ले द गेम. तो चलो जी नेक्स्ट क्वेश्चन पे आते हैं. द 7th वन फॉर टुडे. पेशेंट इज हैविंग दिस मसल वीकनेस विच इज involving the lower limbs with dry mouth and cough, and there's a CT showing a lung mass and the biopsy report is pending. तो थोड़ा सा मुझे पैथोलॉजी में इसने रोक दिया यहाँ पे. Like he said that the guided report is pending and the nerve conduction velocity in this case shows a low frequency repeated nerve stimulation पे decremental response. So I think that will make it very easy for you guys to identify, considering that this is a woman and there's a decremental response on a low frequency repetitive nerve stimulation. Yes, guys, hit the comment button for this one. I think everybody can get this question right. We are having progressive muscle weakness involving the lower limbs. First and the foremost thing is that in this question, I think this is one of the easiest questions that you guys are realizing. I just want to see. Okay, fine guys. So यहाँ पे आप लोगों का आंसर सही नहीं है. The answer to this question is not option number A. अब ध्यान से सुनो, यहाँ टोसिस तो लिखा ही नहीं है. It is lower limb weakness which is given. Lower limb weakness के साथ में there is also presence of autonomic symptoms. Autonomic can be like in the form of dry mouth in this patient. The first and the foremost thing is autonomic symptoms are given in this question. Then is given a CT test that could be showing a lung mass. That could be a possible lung cancer in a patient. And the most important thing is when you will be doing a low frequency stimulation, then you will be getting a decremental response in this condition. But when you will be doing a high frequency stimulation, you will be getting a incremental response in this question. This is not a question of myasthenia gravis. This is not a question of myasthenia gravis. That is what has happened in the, if you have listened to the recall of NEET PG, I've discussed a similar kind of question there also, guys. This is a presentation of Lambert-Eaton syndrome. Lambert-Eaton syndrome में double response होता है. Low frequency stimulation if he says, then it will be a decremental response, and when he will say high frequency stimulation, it will be an incremental response present. So the answer to the current question that is be given to you would be given as option number B. It is not option number A, guys. Auto antibodies against the presynaptic P by Q voltage gated calcium channels. I'll call this question as a silly mistake. While I'll say as a silly mistake is because all of you are aware of the fact that we are having a differential diagnosis of myasthenia gravis. So you were expected to rule that out. I mean, rule that out in a sense, there should be ptosis. There should be D wale features, no? Like in myasthenia gravis, it begins with diplopia, dysarthria, and everything. And then more importantly, the nerve stimulation result in this particular case, the repetitive nerve stimulation part will be having a decremental response initially. So this was more of like a question that was twisted to introduce errors. And that is why the answer in the question will change. The answer to this question is option number B. I hope it's clear to everybody, guys. Do give me a quick thumbs up with respect to whether you are okay with the explanation so that we can move on to the subsequent question. Just waiting for a quick input from you guys so that we can move on. This immune-mediated destruction would be amyotrophic lateral sclerosis. So C is ruled out. Toxin-mediated would be like botulinism, etc. So there was no toxin in this case. You just had to pick up the options which I have currently explained at the moment, and you would be in a better position to then answer. Okay, ji, come on. Yes. हाँ जी, इसमें मतलब woman is a distraction. Woman word is a distraction. लो फ्रिक्वेंसी स्टिमुलेशन इज अ डिस्ट्रैक्शन. तो वही वर्ड्स पकड़ने हैं ना कि लो वरना एवरी टाइम द वर्ड इज ऑलवेज लाइक ट्रेडिशनल वर्ड विल ऑलवेज भी नर्व फ्रिक्वेंसी स्टिमुलेशन ना. यहाँ पे लो फ्रिक्वेंसी स्टिमुलेशन और इसकी वजह से ये वर्ड्स जो है वुमन वर्ड और लो फ्रिक्वेंसी वाला दे आर लाइक द वर्ड्स विच हैव टू बी पिक्ड अप हियर. ओके जी, मूविंग टू द नेक्स्ट वन विच इज much more easier. Patient underwent a lung surgery and the lung histology is shown here. The question then says like which of the following is a leading mutation for this presentation. So you can see the tubular structure. I mean, I can say there is a arsenic or a tubular structure. It looks like gland structure present here, no? Considering that arsenic and tubular structures are present, and then like there are no keratin pearls which are present in this case, so everything goes in favor of a adenocarcinoma of the lung, which is one of the commonest lung cancers. And the mutation that is mainly responsible for this would be EGFR mutation, that is epidermal growth factor. So this is relatively a easier and a straightforward question. Like, you know, there are some questions which would be mixed with the easier ones will be present between the ones which are the trickier ones. So you just need to keep your cool. And like I said, yeah, butterfly on a fence is a good phrase actually. I wish that butterfly on a fence wala zoomed in part is given. Most of the time it is not. So yes guys, please comment. FGFR1 amplification is related to which lung cancer? FGFR1 amplification would be related to which lung cancer? There are no keratin pearls in this case. There is no salt and pepper. So squamous cell carcinoma is ruled out for keratin pearls part, and the salt and pepper, so the lung cancer part is ruled out. Yes, guys. FGFR1 amplification is related to squamous cell cancer. The same squamous cell cancer which is responsible for production of PTH-RP1, and that would explain the development of hypercalcemia present in these patients as well. So 8th we are sorted is option number A. This was more of like a straightforward one where you did not have to make any multiple step interpretations. Let's move to the 9th one for today. This is what you were saying, no? Ptosis in a female, and then there's a diurnal variation that is given. So now you are in a better position to identify like what is going on, because if I say a female with ptosis and diurnal variation, and then I give you a CT chest guided biopsy which is showing a lung mass, actually that could be a distraction again. I mean, it may not exactly be a lung mass. I can say it could be close to the lung. So it's a wrong thing to say it shows a lung mass. I'll just modify that statement. I'll say that CT guided biopsy shows a chest mass would be a much more appropriate terminology for this one. Like instead of saying a lung mass, because it's close to the lung, so that's what he's trying to say from the radiology perspective. Yes guys, I'm waiting for your inputs meanwhile. Whatever you feel like is the correct answer for the one that is currently shown before you. Yeah, this time it would be myasthenia gravis, and therefore antibody against nicotinic receptors at the motor end plate would be the correct answer here. The correct answer for the current question is option number A, and the chest mass which is present in this case looks to be a thymus gland. How do I know it is thymus gland? You can notice a lot of blue trabeculated structures which are present. I mean, normally in the thymus we are able to see the cortex and the medulla separately, but in this particular case, like there are a lot of fibrous septa which are present, and between these fibrous septa there is a dense lymphocytic areas. I mean, this is very densely packed lymphocytic areas present. So this goes in favor of either a thymic hyperplasia or it could be a thymoma as well. But from the diagnosis perspective, this is a thymus mass which is responsible for the trouble in this particular case, and therefore the correct answer for the current one on the agenda would be option number A. Ninth is sorted. I think if you compare ninth one with the seventh one now, and you will be able to realize why, like, a bit of twisting in the data was present. And seventh is that classical NEET PG one where it looked like myasthenia gravis turned out to be Lambert-Eaton syndrome, and then the trick of repetitive nerve stimulation test with this dual response of low frequency versus high frequency stimulation having a differential response should also be remembered. Fine. The normal thymus has pink onion rings that are called as those Hassel's corpuscles. That pink onion rings, they are Hassel's corpuscles. But here, like, the trabeculations were present with dense lymphocytic infiltrate. Okay, moving to the next one, we have this farmer. He is returning from the field, and then this chap, he was bitten by a snake at the CHC. He's having ptosis, a difficulty in counting up to 10, and a areflexia. So looks like a neurotoxic bite, cobra bite in this case, and we've given anti-snake venom. Now the guy is having this joint pain present. The classical thing which is present in this question is the joint pain description. And considering the extensive rash and the arthralgia in this question, he says what is the hyper sensitivity reaction that is present. So since he has mentioned about the rash, that implies that we are dealing with serum sickness, and that would make it the answer for this question is option number C, that is type 3 hypersensitivity. Initially, when the question was being given, I thought ASV was being given, so he could have talked about anaphylactic shock as well, but he decided to describe manifestations that have occurred 5 days later, so can't be anaphylactic shock, and that's why we answer this as serum sickness. And the bite that occurred is a neurotoxic bite that has been given, so ASV, and along with that we might have to give neostigmine to the patient as well. Next, we talk about this 2-year-old kid. He's having recurrent pneumonia episodes. In all of these conditions, they can be recurrent pneumonia episodes, but then there are two key features which are given in this question. The first one is that increased immunoglobulin E levels, and the second one is the delayed dentition part which is given. The main thing is that immunoglobulin E which is given, which will help in identification of this condition as Job syndrome. The correct one here is option number A. And can you tell me the mutation that is seen with Job syndrome? Yeah, A, B, C, D, E is fine. Can you tell me the quick mutation with Job syndrome? The mnemonic part is great. Like, what you have in this condition is that the TH17, I mean, the main aspect is that there is a TH2 dominance, and TH17 is gonna be relatively working lesser. It's TH2 dominance, TH17 is working, right? Yes. And the reason for this would be a STAT3 mutation. So what I wanted to hear was that there is a STAT3 mutation that is going to be contributing to a TH17 underactivity, TH2 stimulation, and the TH17 underactivity explains the recurrent pneumonia part, and the TH2 overactivity explains increased production of interleukin 4, interleukin 5, interleukin 13, and all of them are going to drive up the eosinophils level, eosinophil count of this patient. That is why, like, the eosinophilia is described in this question. As far as Shedek-Higashi is concerned, the main thing is this is a disorder of lysosomal tracking where giant granules in the cytoplasm or the neutrophils would be given. The word is lysosomal. I'll just correct the spelling. This would be a lysosomal trafficking disorder, Shedek-Higashi. The gene is List gene, and there are giant granules that would be present in the cytoplasm of the neutrophils. For Dye-George syndrome, the main thing is thymus will not be there, so यहाँ पे तो T cells नहीं होंगे, and therefore there would be like a combination of hypocalcemia and decreased immunity would be present. And chronic granulomatous disease is the same condition where the dihydrorhodamine test is done and you get infection with that catalase positive organisms, because the respiratory burst which is important for destruction of those catalase positive organisms is not there. So the manifestations of immunoglobulin E were like the main thing for this particular question. Yeah, 2211 for Dye-George syndrome. So 11th is a spot on that you were able to identify very nicely. Yeah, the Fox gene involved for chronic granulomatous disease. But the way the presentation is given, when the remaining options get ruled out by themselves, the Ig levels help you identify the Th2 dominance in this condition due to STAT3 mutation in Job syndrome. Yeah, Steve Jobs is a mnemonic, like instead of doing A, B, C, D, E, what is serum sickness? Serum sickness is development of rash. And along with this rash, they can be like fever, they can be arthralgia. It is called as Arthus phenomenon. That's type 3 hypersensitivity reaction. So you asked what is serum? We gave anti-serum and we gave anti-snake venom. No? There were multiple antigens related to that. I mean, we gave antibodies. So the antibodies will react with antigens which are present with respect to the snake venom that was injected, and it causes formation of immune complexes. And these immune complexes get deposited in the skin. So we get, and in the joints. So that's why we get a serum sickness in the patient. So I think Dipesh, that answers your query. Serum was given. जो serum बनता है वो horse में बनता है ना. And those antibodies will latch on to the antigens which are present in the human body introduced by the snake venom. And that's why like the immune complexes then activate complement and are deposited in the skin and are deposited in the joints. Okay, ji. We are sorted for the 11th one. Let's move to the 12th one. Which cell is responsible for producing circulating antibodies in response to an antigen? So I'll rule out one option for you guys, NAV B lymphocyte. This is mainly for antigen detection. इसका तो काम है कि भाई antigen को ढूंढेगा, antigen detection. And then we'll be having this activated B lymphocyte. This is responsible for proliferation. This is mainly the proliferation that would be occurring. But antibody banata कौन है? तो it is gonna be the plasma cell which will be responsible in this case, that will be producing antibody. And memory B cell, this is mainly responsible for a secondary immune response. Memory B cell is the secondary immune response. So the correct answer for the current one on the screen is option number C. The plasma cells would be producing antibodies, and the remaining cells are responsible for the following functions that I've currently highlighted before you. The answer is C for question number 12. It's just that इसमें error यही हो सकता है कि we might answer an activated B lymphocyte. I said it's mainly responsible for like proliferation and differentiation. In fact, one more thing I should have said earlier, but for proliferation, differentiation, that would be activated B lymphocytes, and then it gets converted into plasma cells which produce these antibodies. चलो कमेंट कर दो फटाफट से चैट बॉक्स में, मल्टीपल माइलोमा में सबसे कॉमन डिफेक्टिव एंटीबॉडी कौन सी बनती है? The most common defective antibody produced in multiple myeloma, that is plasmacytoma. The cutoff in the bone marrow for that condition would be cells more than 10% with crab features present. Yeah, immunoglobulin G is the most common one which is defective. That is why infections are one of the leading reasons why these patients can die. Okay, fine. I think we are sorted for the 12th one. Let's move to the 13th one. The patient has received a shot of benzathine penicillin, and then he's having this urticaria, facial swelling, hypotension, difficulty in breathing. So that's a typical anaphylaxis that is occurring, and he says what is the immunological responses that would be occurring for this particular case. Hit the comment button guys. Benzathine penicillin है, उसके बाद में type 1 hypersensitivity is described here. This type 1 hypersensitivity is what we call as anaphylactic shock. And I put up one more question before you. Anaphylactic shock is which variety of shock? I mean the subtype of shock. And why does it occur? Yes. The main reason why anaphylactic shock would be occurring is, I think Deepak was, and one more person picked up initially. It is not related to eosinophils and it is not related to immunoglobulin E. That is one of the common mistakes that we make, that anaphylactic shock is mediated by basophils. And the cytokine that is involved in this case happens to be interleukin 4 only. But then I can say anaphylactic shock is like the BAP of allergy. It is like a super allergy that is occurring, right? If I was describing a routine allergy, I would have said, okay, eosinophil, I would have said, okay, immunoglobulin E mediated, but I'm not talking about like a routine allergy. I'm talking about like a super allergy that is occurring in a patient where there would be laryngeal edema and the person would be dying. So Pradum, we'll be giving adrenaline in this patient, but at this moment, the main focus is like what is gonna be the cause for anaphylactic shock. So the answer in this case is no बच्चे, it is not muscles. वही तो बोल रहा हूँ, it is not asthma. It is not asthma, it is not atopic dermatitis that we are discussing, guys. We are studying type 1 hypersensitivity from pathology. It is basophil mediated इंटरलुकिन 4 रिलीज, और ये अगर नोट्स में नहीं हो या आपसे मिस हो गया तो इसको फिर हम कैजुअल रीडिंग बोलेंगे. मतलब बहुत बार हम नोट्स में होली खेलते रहते हैं बट देन वी डोंट टेंड टू रिमेंबर द थिंग्स ना. तो ग्रेजुअली यू विल स्टार्ट रिमेंबरिंग थिंग्स ऑल्सो, बट देन इट इज बेसोफिल मीडिएटेड and usually the cause of death in this condition will turn out to be laryngeal edema, which is why you cannot intubate the patient. You have to give adrenaline that is undiluted 1:1000 concentration. But then the main thing for this question was like, why is it happening? So it would be a basophil mediated interleukin 4 that is responsible for this. Fine. 13th is sorted. We move to the 14th one. Which histopathological finding is seen in a liver biopsy of a diabetic patient? HbA1c huge, 12%. I mean, diabetic patients though is like an epidemic nowadays in our country. And then he's asking about the classical histopathological finding that is seen in this patient. So yes, guys, I'll wait for a couple of seconds for you guys to comment on this. Great, guys. Yeah. Okay. हाँ जी, हाँ जी, हाँ जी. यहाँ पे ना बेसिकली क्या हो रहा है कि पीपल आर लाइक टेकिंग इट अ बिट कैजुअली, बट आई थिंक लाइक इट्स बेटर टू टॉगल बिटवीन टू चैट्स इज नॉट पॉसिबल. सो इफ यू कैन जस्ट कम ऑन टू द लिंक इन द ऐप, इट वुड बी ग्रेट. लाइक यू नो द डिस्कशन वुड बी लाइक एट वन प्लेस ओनली. चलो जी, यहाँ पे द क्वेश्चन इज विद रिस्पेक्ट टू लिवर बायोप्सी. सो द आंसर इज नॉट ऑप्शन नंबर सी, किमलस्टीन विल्सन चेंज. Is asking liver biopsy finding in this patient. Liver biopsy finding would be mainly because there's a hepatic steatosis, because diabetic patients would be having increased triglycerides, no? So that triglycerides would be responsible for hepatic steatosis in this patient. So I'm talking about metabolic associated steatotic liver disease. Like earlier we used to call it non-alcoholic fatty liver disease, NAFLD. Now the term is not used, no? Now it is metabolic associated steatotic liver disease, MASLD, that I'm talking about. So the finding in this case would be that in the form of a Mallory hyaline bodies. Counseling bodies are what you read routinely with like apoptotic bodies with hepatitis C, so that is ruled out. Kimmelstein is with respect to the kidney in the glomerulus, and Armani-Epstein changes with respect to the kidney in the tubules. This itself was an NEET question, that which is a finding in the tubules of a patient of diabetic nephropathy. That would be Armani-Epstein change, whereas Kimmelstein-Wilson is the characteristic finding which you read as nodular glomerulosclerosis. But yes, guys, the answer to question number 14 is option number A, and we just need to stop assuming that he will always ask us about liver. Yeah, he will always ask about nephropathy. He is going to ask about the liver involvement in the patient also because of hypertriglyceridemia. Okay. Moving to the 15th one, we have this man. He came to the OPD with a heartburn and cough, and then this 25-year history of smoking 2 packs daily. So he's asking about that dysplasia that you keep on reading, and he's saying what would be the kind of dysplasia that would be encountered in this particular case. Yes, guys. The main aspect is careful reading of this question so that you can identify the dysplasia part. या आई थिंक वही हो रहा है, ए वर्सेस बी ही चल रहा है इसमें भी ना. भाई ही इज आस्किंग लंग्स, what epithelial transformation can occur in the lungs of the patient. तो lung का epithelium जो होता है, that is gonna be pseudostratified columnar, and that pseudostratified columnar will then go into a squamous epithelium. So the correct answer in this case is option number A. Yes, I think बीच में थोड़ा बहुत चैट में भी आया, but then people were able to quickly identify that this question was simply with respect to a columnar to squamous epithelium, because the question is saying with respect to the lungs in the patient. So you can see it's gonna be mixed bag. Like the initial ones, we had a little less response coming up, maybe because the questions were having a bit of pathological slide interpretation. This is more like a fact-based one. Yes, B would be squamous to interstitial columnar epithelium. That would be with respect to patients of GERD, where there would be a Barrett transformation, for which I might have to go in for a punch biopsy in a patient. So answer to 15th is option number A, since the word lung is given, and that word heartburn and cough is just a confounding factor which can be occurring due to cigarette smoking as well. Moving to the 16th one, we have this was, I think, recent NEET only, hemosiderin laden intraalveolar macrophages. We call them heart failure cells, and I think the moment I say the word heart failure cells, it will become very easier for you guys. Yes, guys. Like which of these conditions would be responsible for the manifestation? I mean, heart failure cells would be seen in left ventricle failure, na? Like cor pulmonale in a smoker will mainly contribute to right ventricle failure. So right ventricle failure will not cause a ulta, na? It is left ventricle failure that causes the right ventricle failure, and not a right ventricle failure that will cause a left ventricle failure. Guys, the answer to this question is not option number B. I understand that cor pulmonale looks like a very attractive option considering there's a RVF in a patient, but RVF will not cause a LVF. Yes. Subsequently, I think you guys got it spot on. Dilated cardiomyopathy will cause a left ventricle failure. So this is not due to blood transfusion. So I have ruled out A and D. Construction worker in a cement plant would be asbestosis. It is dilated cardiomyopathy that will cause a left ventricle failure. Left ventricle failure causes pulmonary edema. And when there's a pulmonary edema in a patient, then not only would you be having fluid moving out, but some RBCs can move into the alveoli. Like during pulmonary edema, they can be fluid. And along with fluid, RBC in the alveoli can be present. So the combination of this fluid in the alveoli and RBC in the alveoli is what is ultimately going to result in development of that heart failure cells that will be created, because the RBCs will break down to produce hemosiderin, and that will help in final interpretation. This question I think came in this time's NEET PG as well. I think it is NEET PG or INISET, either of the two. I think it is INISET rather. It was INISET only, the November one, if I remember. And the correct answer for this is option number C. It's a simple logic that you have to apply, and you would be on your way to getting these kind of questions correct. Okay. Moving to the next one, patient comes with the pitting edema for the past 2 weeks. The LFT is normal, serum albumin is 2, a little on the lower side, no 2.5 hona chahiye. The KFT is deranged with massive proteinuria, HbA1c of 10%. So again, like diabetic patient with massive proteinuria. Okay, bilateral enlarged kidneys. Yes, guys, which histopathological report is most likely to be seen? So he's asking you about diabetic nephropathy. Always will be a question on the same. And the most common histopathological finding. The most common histopathological finding that we see in a diabetic nephropathy happens to be diffuse glomerulosclerosis. Because it's saying the word most likely to be seen, so we are answering this as A. If the question said characteristic, like if the question said what is the characteristic histopathological finding of diabetic nephropathy, then we will say as Kimmelstein-Wilson change, also called as nodular glomerulosclerosis. No, bache, I'm getting B in the option as well, but then the characteristic manifestation of Kimmelstein-Wilson change is like the word is characteristic for that, not the most common one. The most common histopathological finding is diffuse glomerulosclerosis. फिर से पढ़ो यार, सवाल ध्यान से पढ़ो. I think you guys are like, in a dilemma with respect to what to answer for this one. Okay, fine. People have gotten the word right. Most likely to be seen. वही है यार, एग्जाम में बैठते हैं ना तो सिलेक्टिव एमनीजिया हो जाता है. वर्ड ब्लाइंडनेस बोलते हैं हम इसको ना, कि हमारा टेम्पोरल लोब ऑक्सी बेटा लोब तो काम कर रहा होता है, बट देन वी टेंड टू बिकम ऑब्लिवियस टू द वर्ड्स which can cause a bit of like errors in our answering. कोई बात नहीं, this is part and parcel of the learning process. So let's move on. चलो फटाफट से कमेंट करो, what test would you do for diagnosis of diabetic nephropathy? फिर आगे चलते हैं. What is the test that we'll be doing for diagnosis? तो भाई ये TNE बनाई इसलिए क्या है कि आपको ये पता चल जाए कि सिली मिस्टेक्स होते क्या हैं ना, एग्जाम में नहीं होने चाहिए ना. दैट इज व्हाट आई सेड, वी नीड टू मेक दिस सेशन कॉन्फिडेंस बिल्डिंग, controlling the errors and closing the gaps वाला session. That is the objective of this one. Yeah, urinary albumin creatinine ratio will be done, and then we'll be starting the patient on ACE inhibitors and SGLT2 inhibitors. But drugs are what I'll talk about subsequently. The answer to this one is option number A. So 2, we have discussed diabetic liver and diabetic kidney. ACR is a good answer. Which of the following is not correct about T lymphocytes? So कॉन्स्टिट्यूट 70, क्योंकि CD4 CD8, चलो आप लोग बोलो, मैं आगे कुछ भी बोलूँगा तो आंसर्स ऑब्वियस हो जाते हैं। एक मैं बोल देता हूँ जो मैं रोक नहीं पा रहा अपने आप को। T lymphocytes are responsible for cellular response, and that delayed hypersensitivity that we have is by T lymphocytes. So delayed cellular response is the type 4 hypersensitivity. You guys comment on the remaining ones. T lymphocytes constitute chunk of the peripheral blood lymphocytes. That is okay. I mean the killer cells and helper cells there. They're derived from the bone marrow. Yeah, B cells are derived from bone marrow. Even T lymphocytes are derived from the bone marrow, and they go to the thymus to differentiate, but the derivation is primarily from the bone marrow. And they're concentrated in germinal centers of the lymph nodes. That would be with respect to the B lymphocytes. No? Like the germinal center part is for the B cells, where the percentage would be lesser. And B cells are for humoral immunity. So I think this was just a fact to be picked up, the location of the cells to be remembered. The correct answer to question number 18 is option number D. Moving to the 19th one, we have a liver biopsy of a jaundiced patient. He's having this jaundice and elevated liver enzyme for 6 months. The chap is an IV drug user, and the serology shows this guy to be surface antigen positive, E antigen positive. IgM class of antibody to the core antigen is negative. So I'll say like this guy is having chronic active hepatitis. But anyway, like the final diagnosis of this guy is chronic hepatitis B. Okay. So chronic hepatitis B का जो classical feature होता है, that would be a ground glass appearance, because there is this surface antigen positive and E antigen positive now, because of the fact that the virus is replicating and surface antigen is present. The virus is aggressively like contributing to ground glass appearance of the hepatocytes. The answer to this particular question is option number B, not option number A. Councilman bodies are like what you read with hepatitis C, primarily the apoptotic bodies, but for hepatitis B, when it is actively multiplying, then we'll answer this as, yeah, Aditya, you're right. This would be ground glass appearance of the hepatocytes would be answered in this case. बाकी स्लाइड में डिफरेंशिएशन आपको आना चाहिए. काउंसिलमैन बॉडीज वुड बी लाइक अ eosinophilic body between the hepatocytes, but if you get a pink material inside the hepatocytes, then it is a Mallory Dank body. Like you can see inside the hepatocyte, this appearance is present. So one is outside the hepatocyte, one is inside the hepatocyte, and the third thing is the ground glass appearance, which can be seen here of the cytoplasm of the hepatocytes here. So three things what I have highlighted is Councilman versus Mallory Dank versus the ground glass appearance for the presentation. I'll say this once again. Councilman body would be like hepatocyte seen, swollen hepatocytes, and then between the swollen hepatocytes are dead one, apoptotic body, Councilman body. Then is Mallory Highland bodies for multiple conditions, Indian childhood cirrhosis, Wilson, primary biliary cirrhosis, non-alcoholic steatotic hepatitis are conditions where you get Mallory Highland bodies. So I'll just mention a mnemonic, though I think there are so many that ma'am has mentioned. So I'll just chip in. I'll mention one for Mallory Highland, that is I will break alcohol status is a mnemonic for Mallory Dank. And the causes can be like Indian childhood cirrhosis, then can be Wilson, CD, 18 and 8 positive. Then is gonna be primary biliary cholangitis, alcoholic hepatitis. So I'll write it as AH, alcoholic hepatitis. And then even in non-alcoholic steatotic hepatitis, this Mallory Highland bodies can be present. As we discussed that NASH or NAFLD is now replated as MASLD. So those would be causes for Mallory Highland bodies. The correct answer for the question number 19th is option number B. We move to the 20th one. This is a lady with a progressive leg weakness and muscle weakness for past 1 year. And then their tongue fasciculations present. Fasciculation is a feature of lower motor neuron lesion. Fasciculation is a feature of lower motor neuron lesion. Hypertonia in the arms is a feature of upper motor. So in the same patient, lower motor, upper motor features are given, which helps you identify that there's only a predominant motor involvement here. He has helped you also by saying himself the word amyotrophic lateral sclerosis. So you just had to use exclusion and answer this as Bunina bodies for this question. The correct answer is C. Lewy bodies are what we read with Parkinson disease. Hirano bodies are what we read with Alzheimer. Lymphoma bodies are seen with epilepsy. So if I look into the exclusion part in this case also, I can final down to the answer for this particular case as option number C only, Bunina bodies for ALS, where there would be superoxide dismutase activity, SOD1 activity that would not be functioning optimally. I mean, superoxide dismutase activity is reduced. And because activity is reduced, therefore, like there's a free radical damage uh, to the cells in the spinal cord as well as in the brain, and that causes a combination lower motor and upper motor neuron manifestation. Answer 20C. We move to the 21st one. Yes. There's a cervical lymphadenopathy in a kid. So initially, like I'm thinking it could be Hodgkin's lymphoma. There's a biopsy report that is given. So I'm searching for any kind of a Reed Sternberg cell. But what I see here is that horseshoe appearance of the cell. If I zoom in, you can see that horseshoe appearance of the cell. That will make it much more easier for you to identify. Like since it is mentioned a horseshoe appearance of the cell, then it becomes an anaplastic carcinoma, and therefore the answer to this will become option number C, that is 2:5. Yes, 1418 is for follicular carcinoma. That is again a non-Hodgkin's lymphoma. 814 and 822 they are for Burkitt's lymphoma. So we have like a clear-cut winner in this case, that is option number C2:5. And the finding that is present in this case would be those horseshoe, or instead of saying the word horseshoe, I can say kidney shaped cells, horseshoe cells, that is also called as hallmark cells. They help in identification of anaplastic carcinoma. In follicular carcinoma, we have BCL2 overexpression that causes inhibition of apoptosis, and that's why the cells will not die. The hallmark cell are a feature of anaplastic carcinoma, and that would again be a non-Hodgkin's lymphoma. The correct answer for 21 is C. Great. Fine, we are sorted for 21st. We move to 22nd. The child is receiving anti-tubercular therapy for the past 3 months, presents with progressive pallor and easy fatigability. And there's a pica history also given. Hemoglobin is low, MCV is low. So either it could be like lead poisoning or it can be sideroblastic anemia. And I need to differentiate on the basis of the slide that is given in this case. Let's look at the answers from your side in this case. I think the best way to solve this question is the word anti-tubercular therapy is being given. So isoniazid would be the one that would have contributed to this. And then in the RBCs, if I'm able to see, like I'll just symbolize it. One is that there are lesions in the periphery. Those blue dots in the periphery are the Pappenheimer bodies, like it can be seen in this case also. In some of the RBCs in the periphery, some of the blue spots can be seen faintly. But if it was like uniform basophilic stippling, then I would have gone in favor of lead poisoning for this particular case, because pica history is also given in this question. But that pica can be a confounding factor. That could be like maybe a lot of kids who are smaller might be exhibiting pica. So we'll not go on the history, only on the history. We'll go by what the slide is telling us. And what the slide is telling us is the presence of those Pappenheimer bodies with a peripheral blue appearance in the cells of this patient. So this is the cell that I'm highlighting about. And therefore the answer is sideroblastic anemia. There are two reasons why the answer is C for this one. One is the intake of anti-tubercular treatment, and second is the blueness which is present in the cells in the periphery. So answer to 22 is C, and I'll show you another slide where like the classical basophilic stippling of the RBCs would also be present. The basophilic stippling of RBCs is a feature that we see with respect to lead poisoning. So 22nd was an easy one to identify. You just need to minimize your negatives for this discussion. This one I deliberately kept as an easy one so that you could identify paint chips and soil, and then you can see the classical appearance of the red blood cells, basophilic stippling. So the answer in this 23rd would be given as like option number A, that is lead poisoning, as the answer to 23rd, in contrast to 22nd where the answer was the sideroblastic anemia part. Okay. Then you can pick up the target cells here for thalassemia. Can you tell me the investigational choice for thalassemia meanwhile? While I'm writing those target cells for thalassemia, like this could be a patient of thalassemia major or intermediate, where large number of target cells can be seen, and that's like the defective alpha defect, like beta chains are not there, so alpha chains will crystallize among themselves, and there would be like alpha 4 tetramers that would be formed. Yes, Dharmesh was the first one to comment for HPLC. Can I have a better answer than that? Can I have a better answer than that? I am having HPLC as an answer. No, guys, I think I have explained this even in my videos as well. Madam also, I saw she was also trying to explain this, that yeah, gene sequencing. The best way for diagnosis of this condition is a gene sequencing. If gene sequencing is not in the options, only then you should answer as high performance liquid chromatography, and if that is not in the options, then you should answer as hemoglobin electrophoresis. So for the same data to be followed for sickle cell anemia as well. The same data is to be followed for sickle cell anemia as well. So it is gene sequencing, it is HPLC, hemoglobin electrophoresis that you need to remember. The correct answer for this question is, the question that I put up before you for thalassemia, the answer is gene sequencing for the investigational choice. Then you can pick up that anisocytosis and poikilocytosis with the peculiar appearance of the cells, which can be seen here. If you look at this cell versus another one, there is a marked change in the shape and the physical appearance of the cell. So iron deficiency anemia. And then is that classical cell for lead poisoning, where the basophilic stippling of red blood cells can be seen. So they are like the easy spotters. Fine. Moving to the next one, Bernard-Soulier syndrome will be characterized by which defect? This is one condition where platelet count will be normal. But in spite of that, the bleeding time of the patient is increased. That is how we realized that we could be dealing with the defect related to the function of the platelets, where the sticking of the platelets would be defective. And since I mentioned the word Bernard-Soulier, you can pick up the word 1B in this particular case. The correct answer to this question is option number B. Bernard-Soulier begins with B, and this condition Bernard, जो Saint Bernard वाली species होती है, that is like a big species. So like you have big platelets in this case. Like the bleeding time is increased. The hint for this question would be peripheral smear that will always mention large platelets in this case. To remember that, remember Viscott Aldrich has small, and Bernard's Saint Bernard species is of large dogs, so it is large platelets, but then they are not able to stick. Big large platelets that don't stick. And what I mean by don't stick is that the addition part here is defective. That is, they're not able to bind with von Willebrand factor, because von Willebrand factor is the tissue glue in this particular case. Yes, Akash, you write for option number A, that would be Glanzmann thrombasthenia, where I can say there would be a problem with respect to the aggregation of the platelets. But for Bernard-Soulier, it's pretty straightforward one. That would be defect with respect to large platelets that don't stick. And if you do a ristosine aggregation test, then the ristosine aggregation test will not correct with normal plasma. There's no correction. The correction will occur with respect to von Willebrand disease, but no correction with normal plasma for ristosine aggregation test for Bernard-Soulier syndrome. Okay. The answer to this is B only. Platelet count is normal with Glanzmann. Yeah, can be platelet, but it's mainly a problem related to again the quality part now, that the aggregation part can be defective in the patient. So we can do like if your query is just limited to the platelet count, yes, platelet count can be normal in patients of Glanzmann thrombasthenia. Yep. Fine. So we can move on to the 25th one. There's a patient with periorbital edema with a massive proteinuria, again very classical, massive proteinuria, hypoalbuminemia, and Congo red staining shows apple green birefringence. I have to put up some that you'll be saying, oh, that is super easy for me to identify. Apple green birefringence is something that somebody is like sleeping in the class or sleeping, they can still answer this as option number A, that would be amyloidosis. Quick comments with respect to what is the, okay. Tell me the antibody responsible for membranous nephropathy. Actually, I was very tempted to put up that question, but then I thought like, okay, fine, after those initial ones, I need to give you a bit of a breathing space. So I thought I'll just mention about the current question as well. Yes, guys. Tell me the antibody which is responsible for causing membranous nephropathy. Yes, yes. Antibody responsible for membranous nephropathy. Yeah, phospholipase A2, anti-phospholipase A2 receptor antibody. I mean, the advantage of this antibody is that especially for primary membranous nephropathy, the need for biopsy has been eliminated. Only for the secondary causes that you need to go at. Otherwise, anti-phospholipase A2 antibody is sufficient for diagnosis for the primary variety. Okay, so upward slanting palpebral fissures, and then is gonna be this 5p deletion that is present. That makes it easy. I mean, Edward would be for 18, Downs would be for 21, Patau is for 13. So this is again a simple one. Credo chat has been asked, so I thought I'll just incorporate this in the discussion as well. 5p deletion for Credo chat syndrome. Yep. Okay. Yeah, 18 trisomy, 21 trisomy. So like that. Yeah. Cat like cry of the baby. If it is given, that makes it even easier for you to remember. If he mentioned cat like cry of the baby, then it's like super easy for 5p deletion. Okay. So we have this lady who has come with the abdominal distension. There is no vaginal discharge. The ultrasound shows a free fluid in the abdomen, and the ovarian mass is also shown. You have to comment regarding the surgical finding in this particular case. Yeah, there is papillary excrescences. If there is like a papillary irregular surface of the tumor, no, so that goes in favor of a serous cyst adenocarcinoma. When it comes to a teratoma, mature cystic teratoma is that classical figure that has already come in the paper. This is the mature cystic teratoma that I'm talking about. But then otherwise, like considering the physical appearance of the tumor which is present here, this would be given as a serous cyst adenocarcinoma that usually presents as like a malignant ascites. The reason for this free fluid in the abdomen is the spread of the tumor to the peritoneal cavity, which is causing a massive ascites. And if you look at the appearance of the tumor, it's like having papillary surfaces or excrescences. That's again a feature that are seen with respect to serous cyst adenocarcinoma. Your teratoma would be having all the germ cell layers, I mean, derivatives of all the germ cell layers, ecto, endo, and the mesodermal derivatives. That is why hair could be seen, but the way this one is given makes it easier for us to identify the appearance of the tumor itself. Let's say. Moving to 28, this is again last time's NEET PG, a relatively 3-4 line question, but very classical. It used to be earlier one-liner question. He wasted a lot of time because you could pick up like lumbar puncture in a patient and purpuric rash. The moment you read those two words, purpuric rash or lumbar puncture being done in a patient, you know that you're dealing with Neisseria meningitidis, and he himself mentioned gram-negative diplococci, and because the person is having it again and again, so he's saying what is the reason. So you know the problem here is membrane attack complex deficiency, that is C5 to C9 deficiency that is responsible here. So answer to 28 is option number B. There are two core things for this question. One is the word purpuric rash and meningitis. Whenever you read about it, it is always Neisseria meningitidis which is to be considered. And he himself had mentioned regarding this gram-negative diplococci as well. For chemoprophylaxis in this case, we have to give ceftriaxone to healthcare workers. We have to give rifampicin or ciprofloxacin to family members. Preferably ciprofloxacin followed by rifampicin to family members. But this guy is himself having it again and again. That's because the killing power is the one which is getting affected. No, rifampicin is not so effective as ciprofloxacin as far as CMDT is concerned. Only the PSM book says rifampicin, that to 70% protection. So it is ciprofloxacin for prevention. 28 is sorted. We look at 29. All of the following act as opsonins to enhance phagocytosis. Opsonins are ones that will make the bacteria more tasty, but one of them is not gonna do that job. So complement 3B. Okay, I'm waiting for answers for this one. All of them act as opsonins except C3A and C5A, they called as anaphylatoxins. Now, they are the ones which would be mainly involved in recruiting neutrophils. I mean, the function for option number D will be that it will mainly be responsible for recruiting the neutrophils. The main function for this would be recruiting the neutrophils. No, guys, all of them, immunoglobulin G, C3b, and mannose-lectin, they all act as opsonins. The function of the opsonin is to make the bacteria more palatable to the security system, and therefore that will help in phagocytosis part. But when it comes to option number D, C3a and C5a, they called as anaphylatoxins, and the main function of these would be chemo. They are basically like gonna be chemotactic factors. I mean, what is C3 and C5a? That's a chemotactic factor, and the function of that is that it will help in recruitment of neutrophils. It's gonna like attract the neutrophils so that you can upgrade the inflammatory response, and the body is meeting up the challenge now. So you're calling in more security guards, right? Like the bad guys have come, terrorists have come, so the terrorists have to be neutralized. So you need more security guards. So you're calling in more security guards. That is complement system C3A, C5A, and then is like making the bacteria or the bad guys more palatable to the security system. That is IgG, complement C3b, and mannose binding lectin responsibility. Yeah, the tasty part is like how they describe it all the time. Fine, I think 29th is sorted. Let's look at 30th. Coilocytes. I mean, we read about coiloonychia, but this time it is like coilocytosis that is present. That would help in interpretation. Yes, guys, hit the comment button for coilocytosis. This would be like, if I say anything, the answer becomes so obvious. Yes, guys, you have to be faster in the answers there. Human papilloma virus, exactly. I mean, there would be human papilloma virus cells that would be infiltrating the cervical epithelium, which is why coilocytes would be present, and that will cause vacuolations, and they can be picked up on a pap smear as well. The infection would be by human papilloma virus. Kaposi herpes simplex virus, KHSV, that would be mainly HHV8, that will cause Kaposi sarcoma basically. So KHS, this is primarily for like KS, that's a AIDS defining cancer. But at the moment we are like, E45 for coilocytes. Exactly, Dharmesh, you have a good point there for like how the virus would be entering into the cells and would be then able to cause neoplastic changes subsequently. Upper esophageal webs is for Plummer-Vinson. Yeah, Patterson-Kelly is the other name for it. Okay, so we are sorted for 30th. The answer is option number A. हाँ नहीं, पहले थोड़ी देर नहीं हो रहे थे, फिर उसके बाद में नहीं होते. चलो अभी देखते हैं आगे कितने वाले सही करते हो, राइट. 35-year-old patient goes a biopsy of the retroperitoneal mass. I need to give you a roller coaster ride, right? तो अभी देखना आगे फिर से वो roller coaster आ जाएगा. हाँ जी, nest of Zalbolin is a feature that is always seen with the pheochromocytoma, or it could also be a paraganglioma because it's written retroperitoneal mass. The tumor could be originating outside as well. So considering that, we'll have to answer it as 24-hour urinary metanephritis for these patients. The answer in this case is option number B. The keyword is nest of Zalbolin and sustangular cells. That would be S100 chromogramin and synaptophysin would be present in this case. And yeah, PhD features are given which make it easy for you to identify the condition. 31st is option number B. Okay, so there is a excised mitral valve that is showing a fibrinoid necrosis, and there are Anishko cells that are present. Then there are Anishko cells that are present, so that will make it rheumatic fever as a diagnosis. That's a type 2 hypersensitivity. And let's look at the answers for this one. No, bachche, it is not an infection of the myocardium. No, it is not a infection. Bhai, infection थोड़ी ना होता है. It is antibodies which are gonna be contributing to molecular mimicry. The key word for like rheumatic fever is type 2. सीधा एक word ही तो पकड़ना है, molecular mimicry for this one. And it's between the beta myosin heavy chains and the M protein that will cause a myocarditis in this patient. The answer to this question is option number A. Rheumatic fever. And yes guys, quickly comment, what is the commonest valvular lesion that is in rheumatic fever with active carditis? Like this particular patient is having molecular mimicry, it is causing carditis. So what valvular lesion will occur? Active carditis would mean that there would be myocarditis, no? Yeah, there is a myocarditis that is present. So that will cause a mitral regurgitation in a patient. Yeah, it is not mitral stenosis. Rheumatic fever with active carditis, whenever is written in the question, it is always to be answered as mitral regurgitation because of the myocarditis component that is present. It's not mitral stenosis. I think all of you are aware of this. Now, mitral stenosis to adult age group में जाके बनेगा ना. Initially, तो it is always gonna, even in older patient, no, at 18 years of age, if somebody is having rheumatic myocarditis, then the Ashkoff nodules will cause heart to dilate. And the dilation will be causing a functional mitral regurgitation in a patient. So it's only later that the mitral stenosis part will occur and the antibodies will get confused and they'll start attacking self. So it's an example of molecular mimicry. Then is leukoplakia, erythroplakia तो पढ़े थे, अभी इसने आराम से पूछ लिया malakoplakia, which is found in the urinary bladder. I think I've sorted the question out for you guys. White patch in the oral cavity due to gutka chewing. आप comment कर देना. Yeah. It is malakoplakia is where Michaelis Gutmann bodies would be present. Malakoplakia is where we read about Michaelis Gutmann bodies. And at the same time, this would be like lesion that can be identified on a cystoscopy. There would be white patches in the bladder, and they would be like, if you take a biopsy from that, you'll be having chronic cystitis with foamy macrophages. So one, we read about Michaelis Gutmann bodies, which are histopathological finding with malakoplakia, which would be white patches in the bladder where foamy macrophages would be found on a biopsy. But if it is gonna be gutka chewing and a white patch, yeah, first is leukoplakia, but then another thing which I wanted to just hear was oral submucosal fibrosis as well, because if the word gutka is coming in, there could also be a possibility of oral submucosal fibrosis occurring in the patient as well. Yeah, Hunner's ulcer is also in the bladder, but then it would be an ulcer. No, Hunner's ulcer is also in the bladder, but then that's again an ulcer in the bladder, and that would not be like a chronic cystitis with foamy macrophages. So that's the difference to be remembered. Otherwise, it will say ulcer demonstrated in the bladder, but for chronic cystitis, that would be malakoplakia. It's like a white patch in the bladder. Answer to 33 is option number B. Yeah, C is for erythroplakia. Yep. Then is gamma Gandhi bodies. These would be hemosiderin deposits, and this time they'll be occurring in the spleen of the patient. The reason for that is portal hypertension, and that portal hypertension would be occurring because of cirrhosis. The main thing is gamma Gandhi bodies would be having iron and calcium deposition. This would be iron as well as calcium deposition in the spleen. The reason for that would be primarily the congestive splenomegaly that is occurring due to liver cirrhosis in the patient. The main reason for why we get a congestive splenomegaly is cirrhosis. Answer 234 is A. Okay, so we are talking about rosets at the moment, two of them. In one of them, you can notice that still some area, clear area can be seen with some papillary projections. Like these are papillary, these are not blood vessels, these are papillary projections that can be present. And in the other one, it is that classical neuropil that can be present here. So if there is a neuropil that is present in this case, yes guys, if you look at, okay, I'm getting like multiple answers for this one. So one, I mean, let me try to resolve it. I mean, it's winter time. So lots of time at winter time, especially if you are at outside Delhi, you can look at the clear sky in the winter with your retina. Especially if you are like close to Dehradun or if you're close to a little bit of sub-Himalayan area, then I can say that your retina can help you in looking at the clear sky in the winter. So I just want you to pick this up from the perspective that winter Steiner word is going to be seen with respect to the retinoblastoma part. And when I say clear sky, the clearance is what is present in the middle. I mean, I said the word clear in this particular case. The clearance is primarily with respect to the central area having papillary projections present. So when it comes to option number B, option number A, which is the correct answer for this one, it is Flexner winter Steiner. How to remember that? In a winter with your retina, you are able to see properly the sky, which is clear. So that's like a Flexner winter Steiner for the selection of option number B from the image that is given is Flexner winter Steiner, and the second one is the Homer Wright rosettes which are given in this case. And if there is a blood vessel that is present inside, then we will say it is a pseudo rodate which can be seen with like a lesion by the name of ependymoma. I'll just give you one more. Yeah, the correct option, the correct answer for this one is option number A, that is Homer Wright rosettes and a Flexner winter Steiner rotates. Yeah, true person is flexible and clear. That's another way you can, I mean, don't bother yourself with too many mnemonics. Like that is how we used to remember it. And if you look at like these three images, then it will become easier for you. Like in one, there is a pale neuropil that is present. Second one is a relatively clear with papillary projection. Third one is like where there is a blood vessel that is present. So that will make it easier for you to identify. First, try to remember retinoblastoma, where there's a flexor intercilia with a clear area. And the second was the Homer right rosettes. And if you are able to see the blood vessel, then you say it is a pseudo-rhodase for like ependymoma primarily. So the correct answer for, okay, I had like people missing up between A versus B. Ulta ho gaya logo ka. So, okay. Yes, that again is a possibility. Like I'll call 35 as a silly. If you got it correct, बहुत खुश होने की भी बात नहीं है. But if you got it correct, तो बहुत बुरा मनाने की भी बात नहीं है. But yeah, I mean, if you got B wrong, then I think that just orientation into trying to remember things is to be focused. So just try and practice out the data. And instead of like, I mean, if you're a mnemonics person, I mean, be my guest. But otherwise, like this image would be available in the PDF, so that will make it easier for you to remember. And if you just look at the representations here, there's a gross difference between the three, so it makes it easier for us to identify the answer to question number 35 as option number A. Okay, moving to 36th for the current one for today. Which of the following is a hallmark feature of a malignancy? Desmoplasia to would be like, fibrous material that would be coming up. The hallmark feature of a malignancy, would be anaplasia, where you would be having is an increased nuclear cytoplasmic ratio, where you would be having intense basophilia present. So the hallmark is like where cancer cells are present. So answer would be C for this one, mainly a fact-based one. Then is the benign lung tumor. So yes, guys. Yeah, answer is C for 36, 37, which is the most common benign lung tumor. Yeah, overall the most common lung tumor is gonna be adenocarcinoma, but yeah, the most common benign lung tumor is a pulmonary hamartoma, for which we can get a popcorn calcification, as can be visible in this image as well. That would be a, yeah, as you can see in this image, that would be a popcorn versus the cannonball mets on the right hand side. Both are images which have been asked earlier, so pretty easy to identify. The one on the right side is the cannonball mets, and the one on the left hand side would be a pulmonary hamartoma. And the commonest benign tumor of the lung will be having a calcification present. That's easily identifiable. Yeah, popcorn appearance there. 37 is sorted. Let's look at 38 now. The lady is having cough and weight loss for 3 months. The biopsy shows lung mass which is having chromogranous synaptophysin. So he is giving us now reasons for this being either oat cell cancer or for being possibly carcinoid tumor. But with both of them, like there can be a possibility of excess production of antidiuretic hormone. So the correct answer for this one is SIADH. Yeah, you were right. Somebody commented B also Cushing syndrome, but then Cushing syndrome is less common as compared to SIADH when it comes to association with lung cancer. So yeah, we'll go with small cell cancer as a probable cause of this one, and small cell cancer the more common overall also, like even if I don't get into that thing of small cell cancer versus carcinoid, SIADH overall is a more common paraneoplastic manifestation that is present between I'll just write it for the sake of completion. Oat cell cancer can contribute to any of the two paraneoplastic manifestations. It can be SIADH or it can be Cushing, but on a comparison basis, like SIADH is relatively more common, where we use Vaptans, where we get dilutional hyponatremia. Okay. Moving to 39th one, we have this man who has come to the hospital with obstructive jaundice. There's a palpable gallbladder in the right upper quadrant, and then there's a ill-defined mass about 3 to 4 centimeter in the head of the pancreas. So he says the answer is hidden. I mean, this is mentioned here only, no? There is a tumor in the pancreas of the patient, and he says like which of the following is responsible. STK11 तो यार प्यूट्स में होता ना. प्यूट-सेगर सिंड्रोम की जो प्रेजेंटेशन होगी वो तो हमाटोमेटस पॉलिप्स की होगी ना. प्यूट-सेगर सिंड्रोम विल प्रेजेंट विद पॉलिप्स. I understand what you're trying to say is that STK11 can have a pancreatic cancer association, but here first we have to think in terms of exclusive pancreatic cancer in a patient. So yeah, polyps can be present, pigmentation can be present, and after the mucocutaneous pigmentation, yes, we can have an increased risk of pancreatic malignancy. So that is okay. But in this case, there is no mention of any polyps and pigmentation. We have to answer this as APC. अरे नहीं बच्चे, एपीसी जो होता है वो तो फैमिलियल एडिनोमेटस पॉलीपोसिस में होता है ना. एपीसी जीन इज फैमिलियल एडिनोमेटस पॉलीपोसिस, जहाँ पे 100 से ज़्यादा पॉलिप्स होते हैं. और जो इंक 4 होता है दैट इज फॉर अ मेलेनोमा. अरे यू गाइस वर गोइंग इटली डिसेंट इन द प्रीवियस क्वेश्चंस. एकदम से लॉस ऑफ कंसंट्रेशन हो गया है ना, कि मतलब कह रहे हैं कि ऑब्वियस वाला चीज़ थोड़ा सा हटा दिया मैंने तो एकदम से एक्सक्लूजन. See, previous questions I gave you a straightforward one, so you tend to get complacent. Now suddenly there's one जहाँ पे exclusion करना है. पैंक्रेटिक कैंसर के लिए मोस्ट कॉमन जीन कौन सा होता है? डीपीसी जीन. डीपीसी का मतलब क्या होता है? कमेंट इन द चैट बॉक्स प्लीज. व्हाट इज डीपीसी? डिलीटेड इन पैंक्रियाटिक कैंसर. डीपीसी क्या होता है? डीपीसी इज डिलीटेड इन पैंक्रियाटिक कैंसर. द करेक्ट आंसर फॉर क्वेश्चन नंबर 39 इज ऑप्शन नंबर बी. मतलब वो हमें लगता है कि यार कॉम्प्लेसेंट हो जाते हैं फटाफट से. इंक 4 इज फॉर मेलिग्नेंट मेलानोमा गाइस. ओके जी. या डी भावना, यू आर राइट. डिलीटेड इन पैंक्रियाटिक कैंसर इज बेसिकली डीपीसी. फाइन जी. सो 39 is sorted. MRCP shows a mass in the head of pancreas. It's pancreatic adenocarcinoma to be considered. Then is this construction worker shortness of breath that you can see in this case with an X-ray that is shown. And yes, guys, I'll zoom into the X-ray also. And construction worker भी दे रखा है. So yeah, there is shaggy margins of the heart. यहाँ पे तो basically shaggy heart है. Shaggy heart is a feature that is always seen with the asbestosis, and because उसने साथ में pleural effusion भी दिया है, so pleural effusion is a feature that is seen with asbestosis. The answer for 40th is option number B. There are two hints for this. One is the shaggy heart and second is the pleural effusion that is given. Both of them are gonna be diagnostic features for asbestosis and not for silicosis. Silicosis वाला जो एक्सरे तो बड़ा क्लासिकल सा होगा कि there would be like that popcorn के जैसा appearance जो रहेगा. That is also called as eggshell calcification. Exactly. I mean, I'll not say popcorn would be an unofficial word. More would be an eggshell calcification around the enlarged lymph nodes that can be present here, because eggshell calcification is what you see with sarcoidosis and silicosis. And then asbestosis, you can see the irregular margins of the heart. That is one. And the second one that you can identify is the pleural effusion, which has been tapped in this patient. So that's why the X-ray is looking much better at the moment. The answer to 40th is Bombay. Then is a hormone responsive liver tumor. The most common benign tumor of the liver happens to be hemangioma. The benign tumor of the liver, the most common one is a hemangioma. Overall is like METS, then is hepatocellular carcinoma. Here it is a hormone responsive tumor that is being asked. So reason of irregular margin, the fibrosis, pulmonary fibrosis that is seen, that's where the shaggy borders of the heart are seen. It's the pulmonary fibrosis associated with asbestosis. नहीं हार्मोन रिस्पॉन्सिव लिवर ट्यूमर मतलब ओसीपी के साथ में कौन सा वाला होता है ना, तो ओसीपी खाने से जो ट्यूमर होता है उसका नाम होता है हेपेटिक एडेनोमा. द आंसर फॉर दिस इज नॉट डी गाइस. इट्स नॉट फोकल नोडुलर हाइपरप्लेसिया है ना. वो तुम स्टेलेट स्कार से को रिलेट करने की कोशिश कर रहे हो, राइट? सो आई एम नॉट टॉकिंग अबाउट दैट. इट इज सिंपल हार्मोन रिस्पॉन्सिव ट्यूमर इज सीन विद ईस्ट्रोजन, एंड व्हेन यू स्टॉप विद द ईस्ट्रोजन then the tumor will begin to resolve. So that is option number B for 41. Okay ji. So 40th was beta, 41 is also Bombay. पढ़ा हुआ है 41. I'm very sure you guys have read it. It's just that temporary lack of reasoning that can happen. Okay, what is true about Klatskin tumor? मतलब वो तो ठीक है कि लिवर मेट्स डिसेंडिंग कोलॉन से आ सकते हैं, but then Klatskin tumor is a cholangiocarcinoma, and that cholangiocarcinoma would be occurring at the common hepatic duct. So that's more of a revision, because बीच में we need to do revision of the common facts that we should be able to answer very fast. Okay, so we are having this girl with diarrhea and abdominal pain. And then there's this pigmentation, there is polyps in the jejunum of the patient. So he says like, what is correct about this condition? I've already solved this question for you guys. Like gluten, ये celiac sprue तो है नहीं है. Celiac sprue is what you see with HLA, DQ2 and DQ8. So that is ruled out. And this c-kit is with gastrointestinal stromal tumor, so it is ruled out. APC gene on chromosome 5 is for familial adenomatous polyposis. So all that is left is genetic basis on chromosome number 19. That would be option number B for 43. Yes, 43rd is sorted. Fine, we are talking about Peutz-Jeghers syndrome in this case, PJS. The mnemonic is JAM ST. I mean, you guys know about it. I don't think so. Any new mnemonic is to be added. The commonest site of polyps is jejunum. It would be hamartomatous polyps, and wo hamartomatous polyps may always, they would be like connective tissue present. So always the teacher will say, or madam would have said about the arborizing pattern that can be seen. That arborizing pattern is because of the connective tissue that's present. And in this condition, there is increased risk of pancreatic cancer, GI, breast, and reproductive tract organs. STK11 is the mutation, and the chromosome involved is 19. 43 sorted. Let's go to 44. Napkin ring configuration on bowel would be seen with colorectal cancer. This would be option number A. That's because of that. That's also the reason for development of that apple core appearance that would be present here. Yes, Sonia, you're spot on that. And yes, Dr. Srinivas, Dr. Kaushik, you're perfectly right. Napkin ring configuration stricture bubble would be colon cancer. Okay. Again, a favorite of our examiners, one testicular tumor will always come, and most of the time it is where there is a symmetrical enlargement of the testis. There is no distortion of the testis shape per se. It has that very clear cut section that is present. And he has mentioned also, like, there's a painless testicular enlargement, high inguinal orchidectomy has been done in a patient. And then you come across with, okay, fine. So what you are seeing here are like very, very clear uniform cells which are present. So these uniform cells, this would go in favor of like, no, guys, this would be a very clear. I mean, if you look at the testis, no, dysgerminoma will always contribute to appearance where the testis mass will be asymmetrically enlarged. This is like a very classical आलू के जैसे potato को काट दिया बीच में से, no, so it's like that आलू or potato that has been cut. So this would be a germ cell tumor that is like a seminoma with a raised PLAP, that is PLAP, that would be increased in this condition. So whenever you read about this, when it comes to like, I think somebody in the chat had commented about dysgerminoma also. तो ठीक है, I mean, when I say dysgerminoma, then specifically what I want you to understand is that there would be asymmetrical enlargement of the testis. It would be more of like a nodularity in the testis, but this is like a very uniform appearance that is present with large uniform clear cells present. So this would be a seminoma, one of the common tumors, and like I think we should keep and try to answer as common things rather than trying to answer as less common tumors. Some of these patients can be having elevated HCG levels also. That HCG elevated is because sometimes seminoma can be having some component syncytiotropoblast, but then otherwise it is mainly the PLAP that would be increased in the patient. Answer to 45 is option number A, guys. Coming to 46, like genitourinary tumors are again something that we have to just practice very well. Yes, guys, waiting for your answer. We have the 70-year-old man with a low backache. A very standard question. MRI shows lesions in the lytic lesions in the lumbosacral spine with nodularity in the posterior lobe of the prostate. So he's like made it super easy for you to identify like there is a tumor in the prostate and this would be an adenocarcinoma. And he's just saying like, how would you be sure about the diagnosis for this particular patient? Yes, guys. PLAP would stand for like placental alkaline phosphatase. PLAP is placental alkaline phosphatase. Yes, guys. Low backache in a man. There can be only two questions for low backache in a man. Either it will be multiple myeloma. If it is not multiple myeloma, it would be a placental cancer that would be asked to you. So I am expecting answers from you guys for this one, guys. Yep. We have to go for a biopsy, na? Simple si baat hai. The question is not asking about a screening test in this case, so it would only be a biopsy that would be done. And yeah, the lesions that are present here will be mainly osteoblastic, or they can be osteosclerotic lesions as well. But the most important thing is that we need to go for a biopsy to be sure. And like single values of PSA are never gonna be diagnostic. They're only gonna be helpful for screening in this particular case. So answer to 46 is option number B, transrectal ultrasound guided biopsy, by which we can then subsequently do a MRI to determine the staging as well, and PET-CT for demonstrating the metastasis to the bones. Most of the time it is like Bateson plexus that would be infiltrated. Okay, so pseudo-Gaucher cells, I mean, normally we read about beta-glucocerebrosidase deficiency contributing to Gaucher cells with that crumpled tissue paper appearance. But this time we are reading about pseudo-Gaucher cells, which is due to increased hematopoietic cell multiplication. Plus the hint given in the question is low LAP score. The reason for low LAP score is कि यहाँ पे जो neutrophils है, they've lost the ability to fight, because it's like poor quality neutrophils which are present in this case. So pseudo-Gaucher cells would be seen with respect to CML, that is chronic myeloid leukemia. That's the reason here is not a decrease in the beta-glucocerebrosidase activity. The reason why like this is occurring is mainly the increased hematopoietic stem cell turnover. And then the second hint in the question was low LAP score. I mean, anytime we read about low LAP score, it means neutrophils are past their expiry date. उनको लड़ाई करना नहीं आता है, and these like post expiry date neutrophils survive only with respect to chronic myeloid leukemia. Yeah, the second condition where we can have a low LAP score is PNH, which is again a disorder related to quality. There the problem in PNH will be that CD55 and CD59 are missing, so we would be having black color urine because RBCs will be destroyed by the complement system, and there would be increased platelet thromboxane into production that will increase the chances of conditions like Budd-Chiari syndrome developing in a patient. But yeah, you had a valid point there. The low LAP values are going to be seen for CML and PNH. PNH a quality ka defect. Quality of RBCs is bad, so they get destroyed in black urine. Quality of white blood cells is bad, that is why low LAP score. And quality of platelets is bad, so increased thrombotic events are present in the form of Budd-Chiari syndrome and increased in like leukomed reaction. Okay. This is again a repeat from NEET PG. We are having a person who was having bleeding. Now, whenever there's an extensive amount of bleeding described in a blood cancer question, and how do I know it is blood cancer? Like hemoglobin is less, the TLC of the patient is on the lower side of normal, and the platelet count of the patient is also low. Then in those circumstances, I'm thinking in terms of possibly DIC that could be triggered by 15:17 translocation. So the case that we're discussing is a acute promyelocytic leukemia. Yeah, the one that we're talking about at the moment is the M3 variety of acute myeloid leukemia, where there is increased chances of bleeding in a patient. In fact, like he can mention coagulogram report also. All the coagulogram parameters would be deranged in this case. And if I zoom in, you can notice those OIR rods. You can see those faggot cells which are present. So all of them point towards diagnosis as AML, for which ATRA would be used. The chromosomal association for M3 variety of acute myeloid leukemia in this case would be, here Dr. Pandey said no, M3 variety will be using ATRA, all trans retinoic acid, for this patient. That will cause differentiation of these cells. That will help in differentiation. Though we have what is called as differentiation syndrome also, for which we can manage by giving steroids to the patient as well. 48 answer is option number A. Okay, then he says, which of the following is the most common type of non-Hodgkin's lymphoma? Inversion of chromosome 16 related to M4 variety, that is okay. M4 and M5 related to gum hyperplasia. Yeah. यहाँ silly mistake नहीं करना है, non-Hodgkin's lymphoma है ना. If it is saying Hodgkin's lymphoma, then it is myxillarity. But if it says the word non-Hodgkin's lymphoma, then we will say DLBCL, that is diffuse large B-cell lymphoma. And only for the Hodgkin's lymphoma, we'll answer it as the myxillarity variety. उसमें भी कंट्रोवर्सी रहता है, इंडिया वर्सेस ग्लोबल वाला, तो इसलिए तो पूछा ही नहीं है ना, वो तो सिंपली पूछा नॉन हॉजकिंस लिम्फोमा वुड बी द कॉमनेस्ट वैरायटी दैट वुड बी सीन. Okay. So we have a patient who's presented with weakness, then is back pain and repeated infections, and the workup shows M spike on serum electrophoresis. So all the data goes as multiple myeloma. And he says like the prognosis in this case would be determined by which of the following. Standard question on prognosis of multiple myeloma. No, it is not A, guys. It is not IgG, which is the prognostic factor. ना, it is albumin and beta 2 microglobulin. ये तो हमेशा स्टैंडर्ड वाला डेटा है that whenever they talk about prognosis of multiple myeloma, whether it's the updated वाला prognostic score or the older prognostic score, it is standard information. Albumin and beta 2 microglobulin are the main prognostic factors for this one. So we are almost at the 3/4 of the way for today's discussion. Which of the following is not a X-linked dominant disorder? Again, one question on these X-linked dominant, X-linked recessive is asked. X-linked dominant has been asked today. Not X-linked dominant one. Yeah, Fabry's is X-linked recessive. No? The correct answer for this one is option number D, that is Fabry's disease, where there would be enzyme affected, that is alpha galactosidase, and there would be presence of angiokeratomas in these patients that will cause acroparesthesias. So answer in this case would be option number D. Yep. You can see the annotation in this case, it is dotted. So what does the annotation indicate in this case? Yeah, the dotted line indicates adoption into the family. Yeah. Answer to question number 52 is option number A. No, adoption out of the family में तो cross लग जाएगा ना साथ में. Okay, I'm getting D also. चारों ही तो है यार, easy तो है. Adoption into the family है. Then there's a slide hash that can be given, that is adoption out of the family. Consanguineous marriage would be like a cross between cousins, and illegitimate child would be like from a single parent, a dotted line would be given like this. Instead of like from a husband or like from a couple, like a line is going in the middle, it would be from any one of the couples that would be present in this case. So the bracket here indicates like adoption, but then if it's a cross which is mentioned, then it can indicate like adoption out as well. Yeah, Bhavna, you have a point there, like the dotted wala na, but then lots of time it is like that cross that is given. The different nomenclatures, but like this one is more reliable to identify the adoption in and adoption out for this one. Considering the image that is given for this one, it would be adoption into the family. Answer to 52 based on the images, like illegitimate consanguineous तो out ही हो गया, बाहर ही हो गया था. So we were left between only like A and B to be considered in this one. 52 is A. Okay, pedigree analysis now. You can see male patient से ही male में disease जाई जा रहा है. Like those hairs on the ears of a patient, so that would be going ahead with a Y-linked inheritance. So it's like males only are transmitting the disease. So only males affected, father to son disease transmission is a Y-linked transmission. But if they change the data where affected father will not transmit to either to the son or to the daughter. I mean, the first one is obviously that Y-linked inheritance that you can see, where like father will be transmitting the disease to his son or the trait to his son, but then the father is not transmitting to either to the son or daughter. Then in the second one, you can notice this would be a mitochondrial inheritance. So two contrasts have been shown here. where you can notice that the father has not transmitted, though like the mother is transmitting to both, to the son and the a son and a daughter, but then the male member is not transmitting in the subsequent generation. That would be a mitochondrial inheritance. And then when you compare with the X-linked dominant, then in X-linked dominant, the affected father will transmit only to the daughter. There would be no son that would be affected. Like if you look here, it's only like the father is transmitting to the daughter. Only the daughters are getting affected. There is no son getting affected. So that would go in favor of X-linked dominant. I said three things here, which I'll say fast in next 30 seconds. In the first one, I said only males affected and father to father transmission. Then is the male is not transmitting to anyone, neither the men, neither to male or neither to female. Earlier it was all, now it is transmission to none. And in the inferior one, you can see that it is only where the girls are getting affected and not the sons getting affected. So that would be a X-linked dominant disorder. So three simple pedigree analysis, which is given, like we used to do that in biology classes long time back. It's just that we are revisiting the same at the moment. Okay, so we have a diabetic patient who has come up on a follow-up visit. You are trying to check his KFT and electrolytes for this one, for this visit, and he says that the sample will be drawn in which vacuum container? Yeah. I'll not say lavender. Lavender is for HB1C, no? Yes, guys, quickly. Your sample will be drawn in which vacuum container for this patient? I want to check his KFT. Yeah, lavender तो HB1C के लिए होता है ना यार, वो तो बाहर ही हो गया. Yeah, I think I mean इसमें भी डाउट नहीं होना चाहिए यार. Yeah, we'll go with option number D only. The yellow one is the correct answer for this one, because I want to check his electrolytes, I want to check his KFT. So answer in this case would be, the blue would be for PT for INR, that is for coagulogram analysis in a patient. Yeah, blue would be for coagulation studies. So for 54, I mean tubes wala coloring, so I don't need to describe that to you. It's pretty straightforward one. Okay. The following tube will be used for assessment of which parameter? You can see a Ventrope's tube here. We use either a Ventrope's tube or a Vestigerens pipette for the same. The Ventrope's tube will be helpful in assessment of which of the following? That would be ESR, that is like the erythrocyte sedimentation rate for the patient. Yeah, the answer for 55 is option number A. Okay, the next one is pretty interesting. Oval fat bodies or a urine microscopic examination. The word is oval fat bodies. I'm rolling out renal artery stenosis. A beta lipoproteinemia we read for acanthocytes. A beta lipoproteinemia we read for a condition where cholesterol will be less and triglycerides will be less. Normally cholesterol and triglycerides are more. Yeah, minimal chain disease is a feature which is gonna be nephrotic syndrome. And nephrotic is where you can be having lipiduria. So the correct answer for this one is option number B, minimal chain disease. Fat embolism syndrome, we just say fat in the urine, but we don't say the word oval fat bodies. Oval fat bodies are characteristic for nephrotic syndrome. When where in pathology, will in laboratory medicine, they'll say the word oval fat bodies is nephrotic syndrome. And the only variety of nephrotic syndrome that is given in the options is option number B, not fat embolism syndrome, though that can be like a commonly misread condition answered in this question. Fat embolism syndrome, because we read about fat in the urine, so that's why like this error of judgment can be present. Yeah, spur cells are like acanthocytes for A beta lipoproteinemia. But in A beta lipoproteinemia, we don't read about like fat bodies on a urine microscope examination. So 56 is Bombay. Let's look at 57. Turbid synovial fluid. Okay, it's getting cut out. There's a turbid synovial fluid where like 100,000 WBCs, and then there is gonna be neutrophils, there is lymphocytes, there is birefringent crystals which are given to be positively birefringent. The moment I read the word positively birefringent crystals, I know that I'm dealing with calcium pyrophosphate crystals. That would be option number A. The presentation is that of pseudogout, for which we'll be giving steroids in the patient. The answer to 57 is option number A. Monosodium urate will always say the word negatively birefringent crystals, so option number B can be ruled out. Then is massive proteinuria with edema and hypoalbuminemia, and then there's a food process fusion also present. So it's talking about food processes and getting involved in a patient. He says like, what is the possible diagnosis in this case? Considering that there is a food process involvement that is described, and then there is solidification of the tuft. Like in some area you can see, like the word that I'm using is solidification of the tuft. The combination of two things, that is solidification of the tuft, and the second is the electron microscopy that he has mentioned by himself, that is that of the food process fusion. The answer in this case would be FSGS, that is focal segmental glomerulosclerosis. We anyway knew that this is gonna be a case of nephrotic syndrome. If the light microscopy was normal, then I would have answered as minimal chain disease. Minimal chain disease can occur in adults also, but considering that there is a solidification of the tuft that is described, and then food process fusion, then it is FSGS. I'll repeat again, if the same question was mentioning normal light microscopy, we'll go by MCD. If this was solidification of the tuft, then it is focal segmental glomerulosclerosis. Then is regarding the G banding in karyotyping. That G banding in karyotyping would be like more of like the barcoding that we do to identify for the heterochromatin and the euchromatin that is present in the chromosomes, and it would help you in doing that numerical evaluation with respect to chromosomes, and some amount of that deletions or like shifts of segments of chromosomes that would be occurring. So answer to 59 would be option number C. It's like a genomic barcode. Like we use a barcode, like a genomic barcode of chromosomes is like G banding. Okay, which renal cell cancer would be seen in patients undergoing a hemodialysis? Yes, guys. Renal cell cancer seen in patients undergoing hemodialysis. Yeah, it is not belly duct. Belly duct cancer is the most aggressive one. That is okay. I mean, whenever you read about the most aggressive cancer of the kidney, then it is a belly duct cancer. But whenever you read about like cancer associated with hemodialysis, then it would be a papillary cancer. The correct answer to this question is option number B. Clear cell cancer is overall the most common one. But since he's mentioning the word hemodialysis, that is why the answer for this question will turn out to be papillary cancer. So the list of cancers of the kidneys where the question has been picked up from. 60 sorted. What is the leading primary malignant brain tumor of childhood? Because I'm saying the word malignant, that is why the answer in this case will turn out to be a medulloblastoma. No, pilocytic astrocytoma is a benign tumor. Pilocytic astrocytoma is a benign tumor. If the malignant word was not given, then I would have answered it as pilocytic astrocytoma. But considering a malignant brain tumor of childhood, we'll answer it as medulloblastoma. Similarly, if he is mentioned benign tumor of adult, then I'll say meningioma. For adults, it is meningioma. For children, it is pilocytic astrocytoma. But for malignant tumor, it would always be a medulloblastoma. 61 is sorted. We move to 62. A tumor that will be having the highest propensity to contribute to tumor lysis syndrome, and it will be having a very high multiplication rate, and that is why like the risk for tumor lysis syndrome would be seen where we get a hypercalcemia, hyperkalemia, hypocalcemia in a patient. The phosphate parts would be elevated, potassium would be elevated, the calcium part will tend to become lesser, and then uric acid in the patient will be super elevated. That will contribute to that acute tubular necrosis in a patient. The cancer having one of the highest multiplication rate and doubling time of 48 hours would be Burkitt's lymphoma. So the correct answer for 62nd question on the screen would be Burkitt's lymphoma. Okay. Fine. We sorted for 62nd. Which of the following is not seen with the stomach cancer? We get Linitis plastica. That's like a leather bottle appearance. So ये तो होता ही है. Then is Virchow's node enlargement. That is like supraclavicular lymphadenopathy present in a patient. Yes guys, iron deficiency anemia versus umbilical bruising. तो iron deficiency anemia होगा ना, because there could be a GI bleeding occurring. Because the person is having a cauliflower growth, so that cauliflower growth can cause a GI bleeding, and the GI bleeding can cause iron deficiency anemia. Yeah. Virchow's node involvement is what is called as Trousseau sign. Trousseau syndrome in fact. Not sign. जो ट्रॉसियो साइन होता है तो टेटनी के साथ में होता है, हाइपोकैल्सीमिया के साथ में होता है, बट ट्रॉसियो सिंड्रोम जो होता है दैट वुड बी अ सुप्राक्लैविकुलर लिम्फेडेनोपैथी. द करेक्ट आंसर इन दिस केस इज अम्बिलिकल में तो वो नोड्यूल्स होते हैं ना, सिस्टर मेरी जोसेफ नोड्यूल, बट यू डोंट रीड अबाउट लाइक अम्बिलिकल ब्रूजिंग इन दिस पेशेंट. सो आंसर इन दिस क्वेश्चन इज ऑप्शन नंबर डी. You mostly would be having sister Mary Joseph nodule, but you will not read about umbilical bruising there. So answer to 63 is delta. नहीं भाई. तो ठीक है, ब्लीड करेंगे ना, ब्रूजिंग नहीं होगी ना, है ना. अम्बिलिकल ब्रूजिंग होता है जैसे पैंक्रेटाइटिस के साथ में होता है ना. दैट इज व्हाट आई एम टॉकिंग अबाउट. दैट ब्रूजिंग पार्ट इज लाइक व्हाट यू रीड विद पैंक्रेटाइटिस. ओके जी, व्हाट इज द मोस्ट कॉमन एक्स्ट्रा नोडल लोकेशन ऑफ अ लिम्फोमा? नौचिकेता ऑलरेडी आंसर्ड योर क्वेश्चन ना. ब्रूजिंग वर्ड पूछा ना पैंक्रेटाइटिस के साथ. No, not ileum, man. Not ileum. Most common external location of lymphoma would be a maltoma, ना. तो maltoma की location कहाँ पे होती है? That would be in the stomach of the patient. The correct answer for 64 is option number D. No, guys, it is not jejunum. Extranodal location of lymphoma would imply the most common location is maltoma. That would be located in the stomach of the patient. The answer to 64 is option number D. आप आइलियम वाले से कंफ्यूज कर रहे हो. माल्ट है ना, म्यूकोजल एसोसिएटेड लिम्फोइड टिश्यू, तो माल्ट इज इन द आइलियम, माल्टोमा इज इन द स्टमक. Malt is in the ileum. Mucosal associated lymphoid tissue is the Peyer's patches that you're talking about, and then is the maltoma part, which would be in the stomach of the patient. Yes. Chalo ji. We can see the tennis racket Birbeck granules here. The question is asking you about the CD association for this. Yes, guys. It is associated with CD1A positivity and CD207. The correct answer for this is option number B. Yeah. That is CD1A and CD207 association for Birbeck granules that are seen in Langenstein histiocytosis, where you would be having lesions in the skull, and the finding in the X-ray skull would be called as a geographical skull for this. Answer to 65 is option number B. 66 is where I think you guys mistook it with the previous question. A woman is having hematuria and then she's having a tumor originating from the medulla of the kidney. He's himself mentioned medulla, and then he's also mentioned a desmoplastic stroma. The combination of the two, like a renal mass having medullary origin and having a desmoplastic stroma, is one of the most aggressive kidney tumors that you would be coming across. So in this particular case, the answer would be given as option number B, that is a Balinese tumor. I mean, when you read your notes, the key word that is written is desmoplastic stroma. High grade pleomorphism is okay. I mean, that is just to increase the diagnostic yield, that word is given. But desmoplastic stroma and then the word medullary origin of the tumor will help you identify Balinese tumor. For chicken wire vasculature, clear cytoplasm, clear cell में तो गलती नहीं होता है, because that is very very simple. Clear cytoplasm, chicken wire vasculature, that is VHL3 gene association, that is clear cell carcinoma called as Gravitz, so would not have an issue. Papillary cancer originates from the proximal tubule. We discussed it is related to hemodialysis. Then is chromophobe carcinoma, where we have that plant cell-like look, and there would be like a perinuclear halo present. But then the most aggressive one that is to be studied is Bellini's tumor, with desmoplastic stroma, high-grade infiltrative carcinoma, and is a rare tumor. The answer to question number 66 is option number B. Yeah, hobnail cells. Fine, Aditya. We next are having a 3-year-old kid. He's having a short stature, and there are almond eyes. That's a very characteristic word. Almond eyes, small hands and feet is brought for evaluation. There is hyperphagia, which is also given in the question, with hypotonia. So, though there is no mention of obesity, but considering that there is a hyperphagia, there is a hypotonia that is associated, the IQ of the kid is also low. So we'll go with not trisomy 21, where there's a mongoloid slant of the eye, so that is ruled out. Yes, that is Prader-Willi only. The mongoloid slant of the eyes for trisomy 21 is ruled out. Chromosome 7 is related to cystic fibrosis, so that is ruled out. So we left with only like the more logical association is the Prader-Willi. Obese is given. Okay. Short stature with hyper. Okay, obese word is given. Okay, fine. That makes it easier. I missed that initial word. I was reading as 3-year-old kid. Fine. Deletion of the long of chromosome 5. That makes it easier for us to even identify even further. Answer to 67 is Bombay. That is Prader-Willi syndrome. Fine. Let's look at the next one. There is this growth in the eye of the patient. There is a greenish tissue mass, which is MPO positive and Sudan black positivity. There's an organomegaly also given in the question. So you can see this sheets and sheets of cells, and then there is this eye manifestation, which is because of the infiltration of the skin by the myeloblast. Why I'm saying myeloblast? Because MPO positivity is given, Sudan black positivity is given. That will make the diagnosis immediately as a chloroma. Chloroma is a myeloblast deposited in the orbital skin, and this is a feature that is seen with acute myeloid leukemia. So, and another hint for acute myeloid leukemia is the organomegaly that is also given in this case, considering that is mentioned regarding the hepatosplenomegaly manifestation here. Yeah, one of the most common varieties of acute myeloid leukemia is the M2 variety that can show an association like this, where the cell proliferation rate is very high, and that can explain like why the tissues of even the orbit can be involved in the patient. Yeah, Shreya and Sonia, both of you mentioned perfectly right the M2 association. 68 is sorted on the basis of the word MPO and Sudan black positivity. Next is a 3-year-old kid had generalized petechian bruise on the forehead. There is absent sternal tenderness. I mean, sternal tenderness is always a feature with the hematological malignancies. There is no sternal tenderness. Organomegaly is not there in this question. And the best hint in this question is that megakaryocytic hyperplasia. I mean, the moment you read that word megakaryocytic, I mean, though that word ideally should not have been there in the question, and you might have to solve it clinically also. But then considering megakaryocytic hyperplasia, it means platelets are being consumed at a faster rate, and I need to, I mean, that megakaryocytic hyperplasia tells me the consumption of platelets at a faster rate. So the cells are trying to compensate by increasing the production, which is why the answer in this question would be given as option number B, that is acute ITP. So answer to 69 is Bombay. Okay. Next is a patient of neurocognitive illness. He fell in the bathroom and is brought to the ER with breathlessness. And then you can notice there are like a lot of infiltrates described in the X-ray of the patient. I mean, there's no X-ray given, but infiltrates are given. The patient has unfortunately expired. And this is again a question that is usually given multiple times, where like you can see that alveoli are literally filled with I mean, neutrophilic, or I can say mononuclear cell infiltrate. I mean, the alveoli are not looking like an alveoli. So considering that the patient has a neurocognitive illness, it could be Parkinson disease or it could be Alzheimer. In fact, first I should write Alzheimer. So there is like either cortical or subcortical dementia. And after that, the person probably had an aspiration, and this aspiration is resulting in development of these infiltrates in the X-ray. And then subsequently, like the even the biopsy finding of the lung is not showing any routine alveolar infrastructure. It is all infiltrated by neutrophils. So therefore the answer in this case is option number B, that is aspiration pneumonia. Pulmonary contusion will be with trauma. Tuberculosis will have a long history. So we are left with, the fat embolism. Fat embolism, then like there should be some fat emboli either present, or like there should be some X-ray finding given of snowstorm appearance for fat embolism. And we anyway, like we would be having GERD criteria. Yes, a good hint, Bhavna, you said was that there is like right side involvement given. That gives more credibility to the fact that the aspiration could have occurred in a patient. So answer to 70 is option number B. Next is about this male with a severe effort intolerance and dyspnea, and there's a left atrial enlargement also present on the chest X-ray of this person. So he says like, yes guys, you guys can comment on the diagnosis in this particular case. The histopathological examination in this particular case would be showing presence of. Yes, so the case is that of acute rheumatic fever, and what you can see in this particular case is Ashkoff nodules, and the characteristic finding that is present there is what is in the form of caterpillar cells. The correct answer for this condition would be option number C. Ashkoff tawara node नहीं होता वो Ashkoff, it is Ashkoff nodules or Ashkoff bodies that are present. It is not Ashkoff tawara node. Ashkoff tawara node is the other name for basically AV node. So this question is just playing with English and our career also indirectly. The answer to this question is option number C. Yeah, I think we had C and D के बीच में चल रहा था. So guys, answer is not D. Ashkoff tawara node is the other name for the AV node. It is Ashkoff nodules, and or it is Ashkoff bodies as a terminology, and the finding inside that is caterpillar cell. That's because of the serrated appearance of the neutrophils that can be present. So some will be like this only, some questions are gonna be like super easy. You will just run through to build up your basic score, and then there would be some that would be pulling down the score. So you need to, in my opinion, like considering the paper that is present, at least I think 60 out of 75 should be correct. That should be the minimum, with the error of at least 10 to 15 that I can understand. But all of them questions should be attempted in the test series. That's the primary objective. And it's to build up confidence, because all questions are not gonna be tricky in the paper. Some are gonna be like super easy, like happened in this time's NEET PG, and even previously also. That there's some which are gonna be like spot on, and there would be some where you'll have to rack your brain, somewhere they'll try to travel you with a bit of terminology. So bas ye mixed bag hi chalta hai. But then the most important thing is the confidence building measure has to be there. It can't be, the whole thing cannot be a torture, right? As what usually happens with most apps, they make it so difficult that person thinks ki yaar aata nahi, to that doesn't, you don't even feel like studying after that. Okay ji, 71 is sorted. Let's move to the next one. A patient has come with blurring of vision, and there is this dot and blot hemorrhages with a microaneurysm, and then kidney biopsy finding is given. So this would be that nodular appearance that is present. That would be a nodular glomerulosclerosis. This would be Kimmersteen-Wilson nodules that are present. So one, I have asked you the diffuse wala, and second I have asked you the nodular wala. Both have been discussed here so that you are like more confident while answering that information. 72 is alpha. Okay. Next is the diagnosis. There's a splitting, clear-cut splitting occurring in the epidermis, and then that row of tombstones, like that appearance is being created. So the moment you read about that splitting in the epidermis, and then there is like a row of tombstones getting created, then this would be a pemphigus vulgaris that we are thinking in terms of. Normally, like the image that is given is of in pemphigus vulgaris is more of that fishnet appearance, but then in this question it's not the fishnet that is given, it was the histopathology slide that was given, which will make the answer very clear for this one. Answer to 73 is alpha. Okay, another very interesting repeat question. Granuloma in the gut. Why not D? Psoriasis. Okay, but then psoriasis would be having a lot of hyperkeratosis, no? Like here you can see that the keratin on the top is not like overtly over the top, I will say, and there would be no split in the basement membrane that would be seen. So Nachiket, 2 points against what you said. The split would not be visible, and the hyperkeratosis part would be like very, very prominent there. Okay, 74th Okay, so we are nearing the end of our discussion, guys. Time flew. Colicky abdominal pain with recurrent bloody diarrhea. And then there is this geographical ulcers on a colonoscopy in a patient. Plus, you can see this granuloma in the gut as well. I'm getting answer as C, intestinal TB. So, TB में तो ileocecal area होगा ना? TB will be having a ileocecal area and it would be transverse ulcers that would be present. No guys, even Crohn's disease में भी तो हम पढ़ते हैं ना कि they can be present. Crohn's is called as granulomatous colitis ना? And colon can be involved in both ulcerative colitis. Colon can be involved in both ulcerative colitis and Crohn's in UC as well as in Crohn's disease. So what I'm trying to say is that the person is having colic abdominal pain because small bowel is involved, and he can be having ulcers in the colon as well. The correct answer for this question is option number B. This is a PYQ, guys. This is again I think a INISET PYQ. You can see the intestinal mucosa ना, goblet cell तो दिख ही रहे हैं. तो goblet cells के अंदर में granuloma दिख रहा है inside the intestine and there is no caseation present here. Because TB में another point is like why I'm not saying TB is because TB में फिर colon में ulcer नहीं होंगे. It would be ileocecal TB ना. It would be ileocecal TB and then TB will be having a caseating granuloma. This is a non-caseating. बच्चे pseudomembranous colitis जो होता है उसमें तो वो होता है ना volcanic eruption. जो pseudomembranous colitis होता है उसमें तो there would be a mushroom cloud, no? It is like a volcanic eruption of a mushroom cloud that would be seen, and that is a feature that is seen with the presence of pseudomembranes in the colon. Here the question is saying colonoscopy shows geographical ulcer, so there is no pseudomembrane which is described in this question. Yeah, antibiotic वाला भी होना चाहिए, and more importantly like उसका histopathological finding would be given as colonoscopy shows pseudomembrane sticking inside the colon. Here it is geographical ulcers present, no? So that's why the answer would not be Clostridium difficile introduced pseudomembranous colitis. But good that we had a chat on this question also. Like pseudomembranous colitis is where there's a volcanic eruption, there is antibiotic intake that is described, and here we can see granuloma. Granuloma is a feature. Non-caseating granulomas can be seen in even Crohn's disease in a patient. So the answer in this particular question is option number B. Yes, guys. So fine, I think I thought we'll work it out faster, but it's okay. I mean, sometimes we can be biased towards TB in India. Something कि वो बड़ा hard to miss होता है कि भाई TB कैसे छोड़ दें हम, है ना? So I understand why like you were like thinking about tuberculosis, but then the history which is given is not favoring that. Especially geographical ulcers in the colonoscopy is not gonna favor presence of tuberculosis. Yeah, fidaxomicin is the drug of choice, doc, for this one. Fine. So we move to the last one, guys. This is the stain that you have to identify. There are a lot of silvers that are described there. You guys can quickly comment with respect to the last one for today. Yeah, this would be a sweet reticulin stain because this would help in identifying collagen in the connective tissue. And as far as Warthinstarian Steiner silver stain are concerned, they're mainly for identification of bacteria. That would be like Helicobacter pylori. So option number A and B are anyway out, and option number C is for neuroendocrine granules. That would be for carcinoid tumor, etc. Option number C is for carcinoid tumor. So I'm left with the only one, that would be Sweet's reticulin stain for the presentation that is given here. The correct answer for this one is option number D. So we are sorted for today, guys. The minimum score that I expect you to get here is something like 50 questions should be correct minimum out of the ones that we have discussed. Ideally it should be more, but I think there were a couple of mistakes also. So I think that would be called as a decent score. 60 would be anyway expected. So रीड पैथोलॉजी अगेन ओके 36 पे आ रहे हैं तो यार आपको मेरे ख्याल से आई थिंक यू गाइस लाइक मैच प्रैक्टिस वी कीप ऑन रीडिंग द नोट्स अगेन एंड अगेन then we keep on underlining also, but then doing MCQs is on the trot like you did with me. We sat for like almost like 2.5 hours almost, and we have tried to analyze the things here, and like in between, like when I start speaking, people are able to answer more effectively, because then when I'm pointing to or directing you towards an answer, you know the answer. So I think you yourself, everybody is realizing that you know the answer to most of the questions. Maybe one or two or maybe max 5 ऐसे होंगे, है ना. 6-7 ऐसे होंगे जिसमें आप बोलोगे कि like one there was between carcinoid tumor versus oat cell cancer slide. So you might say that, okay, I'm not a pathologist that I'm expected to differentiate between oat cell cancer and carcinoid slide in the paper. So I buy that. But for some, like it's just practice, match practice that matters. So yes, I'm gonna be seeing you again next year. The next test is scheduled on 2nd. That would be in the morning session. We are going to be doing microbiology, and these two subjects are like two core subjects for your NEET PG preparation. So keep hammering, guys, and keep working like this. I wish you a great Happy New Year in advance. And yep, I'm gonna see you again on 2nd. That would be in the morning session. The time display would be in the app. For email ID, you can mail me at marwamedicine@gmail.com. Or for the PDS part, as the movement, like I'll just move up in the slide. There was a number on display that I'll just quickly show to you, so that in case you want a PDF related help, then this guy can definitely assist you in the discussion. So it was really fun for interaction for you guys, and yeah, keep on doing the match practice so that we keep on working on such data. Thanks guys, bye bye, take care, God bless you. WPW में नहीं, QRS तो नहीं होता ना, RS कॉम्प्लेक्सेस होते हैं. ठीक है गाइस, टेक केयर, बाय बाय, टेक केयर.